Good morning, Dr. Sujay.
Good morning.
Hi, Sujay.
Hi.
Good morning.
Good morning. Good morning, Dr. Ramachandra.
Morning. Morning, Sujay.
Good morning.
So, good morning, everyone. We are now live and we welcome you to the annual MagnaCode Healthcare and Research Private Limited and Education Trust Conference. Each year we have three conferences, one based in Chennai, one in Bangalore, and one in Hyderabad. This time, because of the COVID restrictions, we are all having to meet online, which is not a bad thing to do because we are able to interact with all the faculties from all the different states at once only, instead of going to different places to meet them. So without further ado, I think I should hand over the session to Dr. KVS Harikumar. Before that, I would just like to explain certain housekeeping practices. The faculty, especially when they are not speaking, please keep your mics on mute. And if possible, keep your cell on vibratory mode rather than loud mode. And we also want to stress that this is not the only day where the session is there. We are having two continuous Sundays of sessions today between 9:30 to 2:30 and again between 9:30 to 2:30 on 14th of February for all those people who are not very busy on Valentine's Day morning. So without further ado, I think I should hand over to the Master of Ceremony today, Dr. KVS Harikumar, to take over the proceedings.
Good morning, everybody. Thank you, Dr. Santosh. The first session on the first day of Magna Endoupdate is celebrating the 100 years of insulin. And we have none other than Professor Ramachandran with us. I mean, sir needs no introduction. Anything to do with diabetes, sir has done it and sir has received it. He is, I mean, the president of Indian Diabetes Research Foundation, and he received the N number of awards in field of diabetes and done path-breaking research in diabetes. And we honored to have your presence here, sir. Thank you for accepting our invitation. And we hope to learn from some of your experiences about how the journey of insulin and how the management of diabetes of some of these things. So we shall have two pre-recorded talks and two live speakers in this session. Sir, I request you to conduct the session. Thank you, sir.
Sure. Thank you. Good morning, everybody. And it's a pleasure. Thank Eli Lilly for inviting me for this interesting symposium about the history and the usefulness of insulin. So let me first straight away go to, of course, we talk about insulin molecule. As you all know, insulin is one of those therapeutic agents in the human medical history which has stood the test of time, and it's finishing 100 years. There is no other therapeutic agent which has proved its worth for so many years. And we have been using it continuously from 1922 and then up to 2022. Although we have changed the formulations, the time of action, the peak of action, etc., but the biological action, the primary action of the insulin molecule remains the same, and it is the same as what was used in 1922 with 10 units in 1 ml and now in up to 300 units in 1 ml. It is the same biological action. So we feel that we have made a lot of strides, but I think after the discovery of insulin, in the last 100 years, we have done something good, but still we have to go a long way. So having said that, let's just take through the speakers. The first speaker is Dr. Ganapathy Bandwal, and he has a pre-recorded talk. He's a member of the Executive Committee of Bangalore Diabetes Hospital. He's the professor and head of the Department of Endocrinology, St. John's Medical College and Hospital, Bangalore. And he has done a lot of research on a number of things other than even diabetes, rheumatoid arthritis, pulmonary complications, etc. Of course, he has also done C-peptide response to glucagon in diabetes. So, and has been principal investigator for more than 50 clinical trials. And of course, he has been a very active member in RSSDI, Endocrine Society, and also in for last 20 to 30 years have been very active. So organizational caliber, educational caliber, and research caliber. All of them he has combined together. So let us now let him talk on, and he's discussing on the journey of insulin from the first molecule, insulin at 100 years, evolution from the iletin to Humalog and beyond. So let's hear and listen to Dr. Ganapathy Banpal. Can you just put his video on? Hari, you are going to do that, or Santosh? Okay.
Good morning. First of all, let me thank the organizers for giving me an opportunity to speak on this 100th year of the World Insulin Discovery Day. So I'll be speaking on insulin at 100, evolution from iletin to Humalog and beyond, celebrating the past, building.
Can you put him back on? We lost him.
Bashir?
Yeah.
So coming to diabetes, a glimpse on its early days. So the earliest description of diabetes appeared in a collection of medical texts in Egypt written around 552 BC, the Ebers Papyrus. Diabetes mellitus and its medicinal remedies were described in ancient India and China. Aretius of Cappadocia, a Greek physician, introduced the term diabetes from the Greek word siphon, as he noted that diabetes causes constant flow of urine, like flowing in a tube-like way. And the great Indian physician Sushruta and the surgeon Charaka in the 400 to 500 AD were able to distinguish between a diabetes type 1 and type 2. So they, at that time itself, they termed them as Madhumeha, literally meaning honey urine. And they described that patients with type 2 diabetic were obese, they had abdominal obesity, and type 1s were lean. And one of the treatments they suggested for type 2 was eating less at that time itself. So before the availability of insulin, the life expectancy of children with diabetes was short, and the prognosis for adult onset diabetes was very poor. Going to the pre-insulin era, during the early part of the 20th century, before insulin became available, physicians Allen and Jocelyn endorsed fasting and calorie-restricted diets for diabetes. So this resulted in some improvement of glycosuria and acidosis, decreased coma, and delayed death among children with diabetes. All diabetics were advised to decrease their sugar and dietary starch intake, and those who were obese were advised to lose weight. The American physician, the famous Elliot Proctor Jocelyn, the founder of the Jocelyn Diabetic Center, one of the first structures offering specialized service to diabetic patients, was a fervent advocate of a severe prolonged fasting and of undernutrition or undernourishment as a cure for diabetes, the so-called starvation diet. So then began what is known as the frustration era. Before the discovery of insulin, a diagnosis of diabetes meant certain death, especially for type 1. In 1910 and later in 1916 in London, Sir Edward Albert Sharpe Schaffer, they described in depth that the pancreatic islands are able to secrete a substance capable of controlling glucose metabolism, which he termed insulin from the Latin insula, which is known as island, with the reference to the Langerhans Islands. Other scholars attribute the invention of insulin to the Belgian Jean de Meyer in 1909. So you can see Banting and Charles Best with the dog Marjorie, for first whom the insulin was given, along with Collip and MacLeod. They all won the Nobel Peace Prize. You must remember that for the discovery of insulin and its other things, the largest number of Nobel Prizes was awarded for this discovery. And the first treated patient with insulin was Leonard Thompson. You can see at the age of 14, weighed just 30 kgs, it was just skin and bones. So the initial clinical experimentation was a failure. He was given administration of 15 ml of pancreatic extract, had no impact on ketoacidosis, only slightly reducing glycemia and glycosuria, and resulted in the formation of a sterile abscess because that much ml was given. And it was not so pure. So that's the reason these abscesses developed. On Jan 23rd, Leonard underwent another series of injection, and this time he experienced a normalization of glycemia, glycosuria, and ketonuria. The blood glucose fell from 520 milligrams to 120 milligrams per deciliter, and the glycosuria dropped from 71 grams to 9 grams, and the ketonuria disappeared. You can see from skeleton some flesh coming in the face. Besides Leonard, Joe Gilchrist, a diabetic doctor, was another patient who underwent the innovative treatment and was also the first patient to suffer from hypotensive hyperglycemia, one of the side effects of insulin therapy. Then began the end of the frustration era. So by February 1922, 6 other diabetics had been given the extract with the same positive results. They called the extract Iletin. It was not until April 1922 that it was given its final name, insulin. You can see the life expectancy post-insulin discovery. The dark ones are the ones which are pre-insulin. You can see the life expectancy was not much, 4.1, 6.3 years, 8, 9. And after that, you can see the number increased to 45 years, 30 years. So at age 50, you can see another 16 years again. This is at age 30, another 30.5 years. At age 10, another 45 years life expectancy. So the increasing life expectancy of diabetic patients attending the George Baker Clinic in Boston from 1897 to 1945, analyzed by the Metropolitan Life Insurance Company. The data exclude deaths within the first week of first observation or hospital discharge. Now then the commercialization of insulin happened, Eli Lilly and the H-Don story. So Eli Lilly was contracted to develop a standardized product, and during the first 5 months of 1923, distributed over 7 million units of insulin, some of which came to the UK. You can see the first insulin commercially available in the United States, and this is how the vial looked like. And this is the other ones, Iletin. It was named as Iletin to begin with. And then the H-Don story. So by the mid-1930s, Hans Christian H-Don and other researchers at the Nordisk, now known as Novo Nordisk in Denmark, had found ways to mix insulin with protamine to prolong its activity. So they found that the semen of the fish actually contained what is known as protamine, and it was found that it could prolong the half-life of the insulin. And they later produced it in a crystalline formulation marketed in 1950 as a neutral protamine H-Don insulin, also known as isopain insulin. Then the arrival of the human insulin came. So Lilly's introduction of genetically engineered human insulin in 1982 heralded the start of the modern era of insulin therapy. Previously, we were using what is known as the post. It was naturally assumed that administering human insulin would yield better responses than bovine or porcine insulin. But as Professor Heller recalls, that was not the case. There are differences of approximately 3 amino acids in human and the bovine insulin. So in the human at A10 and 3 other places, the amino acid structures are different. And that's the reason you find that when you use porcine or bovine, probably you develop more antibodies because they're not matching the human insulin. Unfortunately, patients were rather pushed onto human insulin, and following the switch, there was an increase in the reports of hypoglycemia. Some people were asked to go back to pig insulin, but it's only a small minority who aren't on human insulin today. The great thing about human insulin wasn't that it was better than animal insulin, but that we now had an infinite supply and were no longer reliant on pigs and cattle. This is what Professor Heller recalls. Then the big thing, the arrival of the next big thing in insulin therapy was the entry of insulin analogs. So what they did, they started tinkering with the insulin structure molecule. You have 51 amino acids, and the idea was, see, when you use a human insulin, we require to give it half an hour before food because it's in the form of a hexamer. It has to be broken down into a monomer, and this takes at least half an hour. So then they thought, why can't we tinker with the insulin? The first idea came from IGF-1. So in IGF-1, they find that lysine and proline are replaced, interchanged, and it is in the form of a monomer, and that's how this idea came. They thought, why don't we change this? And they did it, and they found that it could form a monomer very quickly. The first to market in 1995 was the short-acting analog insulin Lispro, marketed by Eli Lilly, soon followed by Novo Nordisk insulin Aspart, and then by the long-acting analogs, the Glargine and Detima. Now, if you see the insulin therapy key developments, in the 1920s, the discovery of insulin and insulin replacement therapy. 1923, Lilly marketed insulin derived from crude extracts of the pancreas glands of pigs and cows. 1982, genetically engineered human insulin developed. 1996, the first rapid-acting insulin analog, Lispro, approved. Today, there are many different insulin available with a range of time action profiles. So you have Lispro, you have Aspart, you have Glulisine, you have Fiasp. So, and a new one of Eli Lilly ultra fast-acting has been approved. Now it's available in India. Clearly, the basal long-acting insulin came. They have different pharmacokinetic profiles. So you can see rapid-acting insulin have short half-lives, 3 to 5 hours, compared with the regular, which is around 6 to 8 hours. The intermediate, the NPH, which is around 12 to 16 hours. The Detima, which is around 16 to 20 hours. And Glargine, 24 hours. Degludec, more than 24 hours, you can say. And then you have also the 2-GIO, which is there. So coming to the evolution of premix. So 1921, isolation of insulin. Then you had the monocomponent animal insulin preparations, which are very pure. Then the human recombinant insulin, example, biphasic human insulin, the mixed starts and all came. Then it came the analog mix, the Lispro mix, the biphasic insulin Aspart, and the insulin Degludec Aspart co-formulations came in 2013. So what was the rationale of doing all these things? So the main reason was we have to control both fasting, postprandial, or both. As you know, basal analogs like Glargine biosimilars, Glargine, Detima, Degludec control fasting blood glucose. The premix control both fasting and the postprandial blood glucose because it contains a component of both short and intermediate acting insulin. You have the various mixtures, 70-30, 50-50, 70-25, 75-25, 70-30 of Aspart. And then which manages to help only the postprandial, like the short-acting analogs, Lispro, Glulisine, Aspart, concentrated human regular, short-acting human regular, intermediate acting like NPH. Coming to the evolution of insulin concentrations and development. So once again, 1921-22, insulin discovered. So the early insulin concentrations were actually 5 units, 5, 10, 20, U40, U80. So this is from 1922 to 1925. Then you had the long-acting PZI in 1936, protamine zinc insulin. Intermediate-acting NPH in 1946. The Lente, which contained an excess of zinc in 1952. And then you had the bovine regular U500 insulin at that time itself, 1952. Then in 1973, you had the U100. And then you had the U100 of the human recombinant insulins, 1982. Then the rapid-acting U100 analog in 1996. And in 1980, the porcine regular U500 insulin was developed. And then you also had a human regular U500 insulin in 1994. We call it as the concentrated insulins. So especially in patients who are morbidly obese, who are requiring very high doses of insulin, we use this U500. And then came the U100 analog insulin in 2000, the glargine. Then the biosimilar long-acting U100 analog insulin in 2014. 2000, then the long-acting U200 analog degludec. Then the iLis Pro U200, and then the Uglargine U300. So the concentrated insulins products can help improve the delivery of insulin when very large doses are needed. An example is Lispro U200 offers advantage of providing a dose of insulin in a smaller injection volume than would be required with U100. So what are the advantages of this? Accurate and precise delivery of low dose. This is the Humalog Junior Quick Pen. So you have even 0.5 also, especially for children. A small increase, 1 unit may produce hypoglycemia, 0.5 may not. So in them, better and more stringent glycemic control, prevention of hypoglycemia, enhanced adherence. So who would benefit? Young children and adolescents, elderly people, adults with insulin sensitivity, adults with multiple comorbidities, pregnant women with diabetes and GDM. So this half-unit dosing opportunity may have a positive effect on the overall A1C, hypoglycemia, and glycemic variability, owing to increased accuracy and precision. So these are the three cornerstones of safe and efficacious diabetes treatment. Other milestones in the insulin research include the vial and the syringe to begin with. Then came the pens, the insulin jet injectors, the insulin inhaler, the continuous subcutaneous insulin infusion pump, the patch pumps, and finally the artificial pancreas or the bionic pancreas. So depending on the system of care, not all options are available in the various countries in the world. To conclude, the discovery of pancreatic crude extracts gave hope to patients with diabetes mellitus. The subsequent development of precisely engineered insulin analogs, which are more physiological, improved diabetes control and reduced or delayed complication. Insulin continues to be the cornerstone of therapy. It is a treatment of choice for type 1. In gestation also, insulin is preferred. And all patients with type 2 diabetes also will, as the duration of diabetes increases, will require insulin because of the progressive loss of the insulin. The entry of newer insulins like Humalog 200, Humalog Junior Quick Pen have added to the required patient needs. Newer medication complement and enhance insulin action tailored towards different mechanisms in the pathophysiology of diabetes mellitus. So a little bit about Eli Lilly, 100-year history with injectable diabetes discoveries, therapies. So in 1923, Lilly produced Iletin, animal-sourced insulin, the world's first commercially available insulin product. 1950, Lilly introduces NPH animal-sourced insulin. Then Lilly introduces Humulin and insulin identical to that produced by the human body and the world's first human healthcare product created by recombinant DNA technology. 1996, the first Lispro insulin rapid-acting analog developed. Then in 1999, the Humalog mix 75-25 mix 50-50 introduced and approved for use in 1999. Then in 2014, Basaglar, a basal insulin, is approved in Europe. 2015, you can see U200 Quick Pen became the first mealtime insulin pen to deliver the same amount of insulin in half the volume per injection. At the same time, they also developed Trulicity, a once-weekly GLP-1 receptor agonist. And 2018, the first half-unit pre-filled mealtime insulin pen becomes available, the Quick Pen. Thank you for patient hearing.
Thank you. I think Dr. Ganapathy gave an excellent lecture on the evolution and the history of insulin for the last 100 years, from the crude pancreatic extract of iletin to the new molecules which are analogs, which has got more predictable action, and the new formulations, and also the new devices. I think without much of time lost, we'll go to the next speaker. And the next speaker is, can we have his Sujay Ghosh? I'll introduce Sujay Ghosh and then he'll go with that. I think the talk was a little longer than what I thought. It's been taking 20 minutes talk. Okay. Okay. Can you put up the slide of introducing Dr. Sujay? Okay. Sujay Ghosh is a dynamic young diabetologist, MBBS MD endocrinologist, and he has his MRCP and FRCP from London. And I don't want to go through the whole thing because he has academic position, professor, and now he's the professor of Department of Endocrinology, Institute of Postgraduate Medical Education Research in Calcutta. He has been also active as an editor and in the journals. He's the editor of Indian Journal of Endocrinology and Metabolism, and also thyroid, and associate editor of International Journal of Diabetes in Developing Countries. So he's been a pretty active person. And he's also been active in the association like RSSDI and have done a number of studies. And we will listen to him now. He's going to talk on insulin initiation and intensification, balancing convenience with efficacy, because just now we heard the history. Now it is time to go for the present times, how you initiate insulin, and those people who are new to this field of diabetes, it's always a question, how to start insulin, what is the efficacy of different kinds of insulin, different people with diabetes. And I think we will now hand over the mic to Sujay. Sujay, you're online, you're live, unlike Ganpati. I hope Ganpati will come online as soon as we finish for question answers. Sujay, go ahead.
Thank you so much. A very good morning, and thank you for that kind introduction. I don't know, the slides went off. Can you see my slides? Hello?
No, it's coming as restart.
Something went
wrong.
Let
go ahead again, share your screen. There you go. It's come. Yeah.
Right. Okay.
Yeah.
Sorry for that glitch. So I'm going to talk about insulin initiation and intensification and balancing the convenience with efficacy. After that talk by Professor Ganpati, who's given us a background about the history of use of insulin, my talk is much more straightforward about insulin initiation and intensification, something that probably we hear in every conference that we go to. So that's my disclaimer and conflict of interest and disclosures. So to start with, one of the things that's very popular in the Indian context is the use of premixed insulins. Unlike most of the Western world, I think in India still, premixed insulins are the most prescribed insulins. That probably has something to do with the marketing strategies of the companies selling insulin in the first place. But are Indians actually very different, which would actually justify why we have been using so much of premixed insulin in the Indian context? So all of us are aware of Monier's paper, particularly to suggest that as HbA1c goes up, the contribution of fasting glucose is more to the contribution of A1c as compared to postprandial glucose. But there are now several Indian studies to suggest that postprandial glucose levels play a very important part even when HbA1c goes up. So at lower levels of A1c, postprandial glucose is important. At higher levels of A1c, postprandial glucose is very important, at least in the Indian population. Whereas in the Western counterpart, the postprandial glucose contribution is perhaps more when the HbA1c is relatively closer to target. Whereas as A1c increases, it's predominantly fasting hyperglycemia that contributes to A1c in the Western population. So therefore, we do understand that meal patterns and meal content, particularly the carbohydrate load, probably in Indians is very different, as a result of which postprandial blood glucose is very important. And if you look at guidelines and recommendations, whether it's the ADA or the AACE, which clearly recommend basal insulin for initial insulin initiation, and the IDF, which is perhaps more akin to the developing world and their dietary patterns, they do give the option of using premixed insulin in addition to having the option of basal insulins. And if you look at our own RSSDI guideline, it's pretty open, and it kind of tells you, you can probably start insulin with any of the insulins that you wish, and probably baseline parameters, baseline features, and certain particular aspects, some disease related, some individual patient related, which will decide which insulin you start with. Now, one of the facts that happens in India is that we initiate insulin very late, as a result of which, by the time a patient is initiated on insulin, he not only has deficiency of basal insulin component, but also has prandial insulin deficiency, and only basal might not work in such circumstances. So the Indian National Consensus Group on insulin suggested that, we could think of premixed insulin as one of the easy, safe regimes to initiate insulin with. And the pros in favor of it is it's relatively easy to start. You can even start premix once a day, leads to good control of not only fasting glucose, but also postprandial glucose, unlike basal insulins, and lowers HbA1c significantly. And once you start someone on premix insulin, you can actually intensify with the same premix insulin, unlike in a basal insulin where you will have to add prandial components to it. If you look at the flip side of things, there's slightly more chance of having hypos with the premix, and probably there might be compensatory overeating, as a result of which there might be weight gain, and you might need 2 or more doses. And even if you're using 2 doses, usually it becomes difficult for the post-glucose to be lunch glucose to be controlled. And probably the worst controlled blood glucose in such scenario is the pre-dinner blood glucose levels. So what do Indian physicians think, and what do they choose, and why do they choose? What does data tell us? As far as Indian physicians are concerned, again, please remember this has some certain things to do with the way we are in terms of our diet, the high carbohydrate content, and the delayed insulin initiation. And of course, because of perhaps very, very strong marketing reasons as well. In India, whether you're looking at adults, whether you're looking elderly who are frail, or those with restricted daily activities of living, still you can see that premixed insulin is probably the commonest prescribed premixed insulin. And this is quite remarkably established by the recent IMPROVE study that got published. So when we are choosing an individual to receive insulin, and we decide that this is someone that I'm going to start on premixed insulin, there are certain things which probably prompt you to start with premixed insulin. One of which, like I said, if the postprandial increment is pretty high. I'll just give a classic example. If somebody has a fasting sugar of 200 and a post meal of say 230, initiating with the basal insulin does make sense, because once that 200 fasting becomes 100, that 230 postprandial becomes 130. However, if your starting fasting glucose is say 200 and your post meal is 350, just starting only basal insulin is not going to work. So you try to look at the meal gap, that's the postprandial increment, and if it's more than 54 as suggested in this particular paper, it suggests that there's a problem in terms of prandial insulin deficiency. The other thing that has been looked at is the fasting glucose to A1C ratio. Again, here this also indirectly reflects the contribution of postprandial glucose to the A1C. And if the difference between the bedtime and the morning glucose value is more than 55, then consider prandial insulin component addition, because only fasting will probably not help. Then there are several psychological factors as well. It's much more easier and convenient to teach someone to get on to, say, premixed insulin, rather than having to start a fasting, basal, and then having to add one at a time prandial. And with the same insulin, you can probably intensify in future. Adults at earlier progress stage of disease and elderly patients need a simple therapy. And particularly if these are individuals who've got relatively restricted or limited lifestyle patterns, relatively rigid lifestyle pattern, high carbohydrate diets, and where you need a simple, easy to explain insulin therapy, this could probably be the reason. So a very quick look at a case to try and see the role of premixed insulin in patients uncontrolled on OADs. Remember, whenever we talk about cases, there can be many more than one answer. But just to summarize this case, this is a 48-year-old lady, has had diabetes for 6 years, A1C is almost about 2.5 to 3 percentage point above target range. At last visit 6 months ago, weight is 72, BMI is on the higher side. And if you look at the fasting PP, both raised and the gap being more than 100, clearly telling us that there's a prandial insulin deficiency in this individual. And not surprisingly, the lipid parameters are also not that very well controlled. So the blood glucose is not controlled. The individual is on triple drugs, a DPP-4, an SU, and metformin. Family history of heart disease in father at a relatively young age, and is a banker, probably therefore physical activity is not going to be great. Has got a urinary tract infection, probably this case trying to tell us, please don't use an SGLT2 inhibitor, though that's not probably the case. You can probably use SGLT2, and you can probably use a GLP-1 in this scenario as well, replacing the DPP-4, though I'm not very sure, even with the addition of those two, you'll get the A1C down by 3% or 2.5%. So that's probably the reason why we would think of going for an insulin. And if you look at those options, therefore, adding another option of OAD will probably not help us reach targets. The last option of adding a basal insulin alone will not take care of the prandial insulin, prandial glucose control. Replacing the DPP-4 with the GLP-1 will definitely help with the weight, but still probably not reach targets. So probably here, either you've got to think of a premixed insulin or a basal bolus insulin, or at least a basal plus insulin. So let's talk about the why, what, and how of premixed insulin initiation. So when we are talking about initiation, you can think of either a basal insulin with keeping the drugs, or traditional BIDS therapy, that's bedtime insulin, daytime sulfonylurea kind of regime, or you can think of basal with prandial insulins, or you can think of premixed insulins. And we've tried to highlight here the glycemic factors and the patient factors for the choice of each of them. For the basal one, you would choose it if it's only fasting glucose raised, whereas daytime blood glucose is okay. It's easy to start, patient is easily overwhelmed, therefore give him just a single shot of insulin. For a basal bolus, of course, where you're trying to achieve intensive control, where the lifestyle of the individual is erratic and you want to provide him flexibility of lifestyle. Whereas premix for individual with both fasting and post meals are high, A1C is off target, where 2 or more meals are predominant, and where there is a regular lifestyle pattern. So that once you've injected something in the morning, he's going to follow the same lifestyle and not run into problems through the day. And what insulin therapy in type 2 diabetes, which regime? Like I said, premix would favor if your postprandial increment is more than 54. Is the patient likely to manage basal bolus therapy when intensification is needed? If yes, then start with the basal insulin. Carbohydrate load very high, wherein it's no more than 2 large meals, then go for a premix. And if the lifestyle is predictable, go for premix, otherwise go for basal insulin initiation. Now, this is a study of looking at Humalog mix 25 given twice daily plus metformin versus glargine plus metformin. I think it's not fair to compare, such regimes, because you're trying to compare apples with oranges. You're comparing one basal insulin with twice daily premix insulin, and obviously it depends on the kind of patients that you choose in a clinical trial. If you choose it in someone who's got high A1Cs to start with postprandial hyperglycemia, obviously the premix insulin is going to show better results than the basal insulin, and that's exactly what's reflected in this study. And therefore, the other bit that we're looking at, say for example, if you start someone early on insulin, someone with basal insulin versus someone on premix insulin, obviously the premix insulin is going to have greater durability, because we know type 2 diabetes is a progressive disease, and what would be controlled with basal insulin alone at one point of time, over a period of time, it's going to run out and you would need prandial insulin. So the study is actually reflecting what the normal pathophysiological abnormalities actually happen. So coming back to this initial case that we were talking about, the patient was started on Lispro mix 25 once daily, gradually up titrated. The second dose of Lispro was added at dinner time. Gradually, both were adjusted. Initially, the patient had some degree of hypo, but no severe hypos. And at 3 months, did have a good reduction in HbA1c, almost 2 percentage point, at the cost of a 1 kilogram weight gain. So again, if we compare basal versus the premixed insulins, if fasting glucose control with basal is going to be very good compared to a premixed, postprandial reduction obviously is not going to happen to the kind of extent that you want, because there is no prandial component in the basal insulin. A1C reduction is going to be greater with the premixed insulin. Hypoglycemia, probably the risk is going to be more with premixed insulin. Convenience of initiation with the basal is going to be more. Titration is easier with the basal. And when you're talking about intensification, you can use the same premixed insulin which you use for initiation to go for intensification, and both have robust clinical data to support the use of either. So when we are talking about intensification, I'll talk about the second case, a 71-year-old lady who's on metformin twice daily, liraglutide. Voglibos was withdrawn. She was on premixed insulin twice daily. And if you look at the blood glucose readings, both the pre-meals as well as the post-meals are high. A1Cs are high. In that scenario, you can probably, in India at least, or even in my practice, I don't tend to use premixed insulin thrice daily. But one of the options could be you could use premixed insulin thrice daily. If you feel that you won't need more of prandial glucose control, you can switch over from a 25-75 or a 30-70 to a 50-50. So one of the things, if I go back, you can see because of the predominantly high prandial glucose values, you might even thinking of switching over to a 50-50 insulin, either at breakfast and lunch, and a premixed 25-75 at dinner time, because the fasting is not that bad. Or you can go for a full basal bolus insulin regime. And like I said, there can be no one right or wrong answer. And it depends all on what the patient likes, the flexibility, the lifestyle. You can probably choose all of them, including all of the kinds of premixed insulins that we are talking about. And again, looking at this study to look at A1C reduction of Lispro mix compared to basal bolus therapy. Again, the choice of patients, the trial designs often determine the results. This kind of tries to show that in this particular population where this study was done, the results seem to be similar, with similar A1C reduction and similar nocturnal hypoglycemias. So when we are intensifying, if you are thinking of premix versus basal bolus, there are a few pointers which could help you. If you want fewer injections, go for premix. If you want to go for a less frequent monitoring, perhaps premix. And if the patient is unable to, take multiple injections, needs a carer to help out, then probably a premix is okay. But most of the time, if perhaps I have to choose someone who is willing to take multiple injections, who's comfortable with more monitoring, who needs more flexibility of lifestyle, then favor a basal bolus. And the more insulinopenic you become, favor a basal bolus regime. So back to this case, this lady was switched to a premix 50 twice daily before breakfast and lunch, and Lispro 25 before dinner. Very, very complicated regime, I have to accept, because it's going to be very difficult to titrate such a regime. And at the end of 3 months, her A1Cs seems to have improved. So if I have to summarize, there's significant contribution of postprandial glucose, even at higher A1Cs in Indian population as compared to Caucasians, for the reasons that I explained, because of the meal pattern and the meal content. Premixed insulins are definitely simple to start with single injection with effective A1C control targeting both fasting as well as prandial glucose. Uncontrolled on 2 or more OADs with flexible lifestyle should be started on premixed insulin, and doses can be titrated on every, say, 5 to 7 day interval. Premixed insulin themselves can be used to intensify insulin therapy. 3 times pre-meal analogs are used. There is evidence for the same, have been found to be non-inferior to in some of the studies to basal bolus insulin. Premixed insulin provide both convenience and efficacy to the patient and contributes in a long way in achieving the patient's glycemic targets. I shall stop there. Thank you very much.
Thank you, Sujay. That was a brilliant lecture on initiation of insulin. And you appropriately said that in India, premixed insulins are actually preferred to start with. And you also explained the reasons for that. Of course, I think this has been very useful for people who are listening to the talk about initiation of insulin. There has been almost 10 to 11 studies comparing basal insulin analogs to premixed insulin, starting from Galapino study by Ashner, Matthew Riddle, landscape study, etc. Of course, looking at the outcomes can be measured by efficacy, looking at the HbA1c, the frequency of hypoglycemia, the total insulin that you have to use to attain a HbA1c, and also looking at the overall weight gain, etc. Of course, cost is a simple thing. So therefore, there have been some conflicting results on this. But having said all this, premixed insulins are preferred in the Indian population to a large extent for many reasons which you described. Okay, now let's move on and we'll have the discussions after all the talks are over. Next speaker is Dr. Matthew John. Can you put up the slide to introduce Matthew? Of course, everybody knows him. He's from Kerala. Matthew is an endocrinologist at Providence Endocrine and Diabetes Specialty Center in Trivandrum, DM from Mother in Bombay, over 40 index journal publications. Has been investigated in a number of phase 3 trials, and he has done original work in diabetes, osteoporosis, and growth hormone, and also have been active in the organizations. Matthew is going to talk to us on the third topic today, insulin for in-hospital hyperglycemia management. Matthew, you're on.
Yeah, thank you, sir. I hope my slides are visible.
Yes.
Yeah, thank you, Santosh and the MagnaCode people for inviting me. And I think it's the third or fourth time I'm speaking here. These are my disclaimers. I've been contracted by Lilly for this meeting. And I'll be looking at insulin in hospital hyperglycemia management, and I'll be concentrating on non-critical care settings. So if you look at inpatient hyperglycemia, this is in fact a very common condition. It could be because of a prior diagnosis of diabetes, or people who are getting admitted with some other medical condition being detected to have a hyperglycemia in hospital. In fact, close to 50% of non-critically ill hospitalized patients, especially above the age of 20 years, are found to be having some form of hyperglycemia during evaluation. Excuse me. People with diabetes are always at a higher risk of hospitalization, and it has been seen that people with an in-hospital hyperglycemia documented still continue to have an increased risk of hospitalization over the next 1 year in comparison to people without inpatient hyperglycemia. And it is estimated that 20% of all adults discharged from the hospitals do have diabetes, and they require repeated admissions. We'll start off with a case just to explain how this has to be approached. So this is a 40-year-old male with he's 80 kgs, hypertensive, admitted to the ward for workup of pyroxia of unknown origin of 3 months duration. Appetite is mildly reduced. He was never known to have diabetes. And as he gets admitted, the random blood glucose is found to be 190 milligram per deciliter. So what do you do for these patients? Whether you want to do an A1C or go for a blood glucose monitoring, or take this as an elevated glucose and go for further treatment immediately. So basically, patients like this require a monitoring to confirm that they have persistent hyperglycemia is there. And second, you need to do a glycated hemoglobin to find out whether they have a pre-existing diabetes, because we don't know the history of this patient. So this patient underwent both these things. His glycated hemoglobin has been found to be 7.5%, and monitoring over the next 24 hours with glucometer has shown that he's got an elevated glucose levels. So A1Cs have been found to be useful even in critical care settings. There are studies to show that within a 1 month interval, there's not much change of A1Cs between in-hospital patients versus outpatient measurements, show that it does not get significantly altered during critical care or even during in-hospital admission. So once you see this sort of values, how do you like to proceed further? Whether you want to start on an oral agent, this patient is, say, with a PUO, so he's not going for any surgical management. Whether you like to put this patient on a sliding scale regime or go for a basal bolus insulin, or being a very sort of stable patient, whether you would like to just put him on premixed insulin. So this is how the protocol runs when you see a patient who comes in to the hospital. Blood glucose should always be recorded. And in fact, there is now a current recommendations that even in pediatric patients getting admitted, blood glucose should be recorded, because there have been a lot of cases of patients with diabetic ketoacidosis getting missed because of glucose being ignored in children getting admitted with diabetes. So for this particular patient and for general inpatient admissions, ask for history of diabetes. Whether there's diabetes present or not, look at blood glucose monitoring. So no history of diabetes and the blood glucose is persistently less than 140 milligram per dl. Look at the patient's clinical status and consider blood glucose monitoring. More frequent monitoring patients who are critically ill, and less frequent monitoring for patients who are not critically ill. The patient does not have a history of diabetes, but the blood glucose at admission is more than 140. Then you need to keep the patient under monitoring for the next 24 to 48 hours and go for an A1C measurement. If the A1C is more than 6.5, consider this patient has possibly got diabetes and treat accordingly. And a patient who's got a past history of diabetes, whether on treatment or not, should have a regular blood glucose monitoring. So how do you proceed further with this? As I told you, go for that monitoring and A1C as you get in. And if the patient is already on oral hypoglycemic agents, generally it is better that you continue the oral hypoglycemic agents when you have an admitted patient, except in the case of patients who are very well controlled and coming in for a very minor surgical procedure. Go for regular monitoring. Once you have a reasonable number of monitoring in place, make an insulin regime which is fit for the patient. And always realize that these patients who are inpatients may go for various procedures during the course of their illness. They may be taken for an ultrasound at short notice. They may be left in the ultrasound department for 1 or 2 hours because there's a delay in the previous patient being examined. So things like that are to be expected in hospital patients, and regime should be modified accordingly. Make it clear that how hypoglycemia should be recognized. It's always good to have institutional protocols and how to treat hypoglycemia in the hospital. And then finally, once you're through, plan for a discharge. So what is the sort of levels that you recommend? In the ICU, blood glucose levels of 140 to 180 milligram per dl, and intravenous insulin infusions are the best method of delivering insulin in the intensive care units. In non-critical care settings, that means in in-hospital patients, pre-meal blood glucose ideal targets are less than 140, and all blood glucose at any point of time less than 180 milligram per deciliter. When you start treating patients, realize that you need to modify regimes in hospital when the glucose goes below 100, and definitely the regime has to be changed if it goes less than 70 milligram per dl. You could keep more stricter targets for patients who have been having well-controlled diabetes over a period of time. Now, when it comes to glycemic therapy inside the hospitals, generally OADs are not recommended, but there are now certain guidelines which are put in place to possibly look at the use of incretins as in-hospital use, but generally we always prefer to have insulin as the major thing. And if the patient is in the ward, a subcutaneous regime of basal bolus insulin, frequently reviewed, frequently modified, is the recommended one. And for ICUs, as I told you, it is an insulin infusion. So the basic principle, whether you're treating patients in the outpatient or in the inpatient, is to mimic a normal physiological insulin secretion, and that will be best possible with a basal bolus insulin regime. You could consider the use of premixed insulin regimes in patients who are very stable, previously on premixed insulin, and having a very fixed meal pattern inside the hospital, and you feel that they are not going to get disturbed during in-hospital stay. But for most patients, a basal bolus regime will be the best form of insulin delivery. That helps in more finer titration and more flexibility in terms of insulin delivery. There's a system called the sliding scale of insulin. I think most of the institutions are gradually given up this method of insulin delivery. Just to recapitulate what really sliding scale is for the delegates who are listening to it, if you are practicing sliding scale insulin, it is always good to reassess that strategy. So basically, as the patient gets into the hospital, a regime like this, what you can see on the right side of the screen, is usually put up. So you have a certain glucose value which comes in. You give a certain big amount of insulin. Like example, in this particular picture, if you have a glucose between 150 and 200, you give 2 units. 201 to 250, you give 4 units. So this sort of regimes are usually easy to implement because you need to just put it in place and the system can keep giving the insulin doses. But what basically you're doing is, this is not at all physiological. You don't have a basal insulin requirement. The normal basal insulin requirement of the patient, which is in fact going up during a hospitalization, is usually not met. And you're trying to treat an elevated blood glucose. And when you see a normal blood glucose, like say 151 or 100 to 150, you are not treating the patient. So the next blood glucose keeps going up. So finally, you have a patient who ends up with a sort of roller coaster in terms of glucose. You treat the high glucose, and as the glucose becomes normal, because you don't treat, the next glucose is going to be high. So using sliding scale insulin as a single strategy is preferably be avoided. If you're using such a strategy, always have a basal cover along with that. The best effective strategy is to go for a basal insulin strategy. I think I don't need to explain it really, but just to say it in a few words, you have a basal insulin, that is a physiological basal insulin requirement, just like the normal human body, should be done. A prandial insulin, which is based on the pre-meal glucose and the sort of food the patient is going to eat, will decide the prandial insulin requirement of that particular patient. So this particular patient, which we saw in the beginning of the discussion, has to go on a basal bolus insulin regime. And how do you decide the basal bolus insulin regime? How much do you want to give to that particular patient? It is very approximate thing to start off with, and then you modify based on your self-monitored blood glucose or the glucose monitored by the nurses. So you calculate at something like 0.2 to 0.4 units per kg per day. Whether you like to calculate at 0.2 or 0.4 decides on the patient characteristics. If the patient is lean, the glucose is not too high, you are on the lower side of the dosing. If the patient is having obesity, the patient is having insulin resistance, or patients had a higher requirement of oral hypoglycemic agents prior to hospital admission, you go on a higher dose. Or if the patient had a higher insulin requirement a priori prior to the admission, you always err on the side of a higher dosing in keeping with the patient's pre-existing dose. And now once you calculate that, you can give 50 to 60% of this as the basal dosing and the rest of it as a nutritional or a prandial dosing, and give correctional boluses along with that. And always remember that these patients may go in for procedures and you may need to frequently modify the regimes. Now, this particular patient is 80 kgs. So you calculate at 0.4 units per kg body weight. You can see 0.4 into 8, 32 units. And you can split it as 6 units with breakfast, lunch, and dinner. And bedtime, you can give 16 units. That's 50% you're giving as prandial dosing, split into 3, and 50% you're giving as a basal dosing. Now, all is well when you're giving certain doses and sugars are perfectly on target, things are fine. But look at this particular case scenario. You started at with Humalog 6, 6, and 6, and glargine of 16. You can see the fasting glucose is perfect, is 102. So you give the patient 6 units of Humalog. And see what is happening in the pre-lunch period. Your pre-lunch glucose is 260, but 260 is elevated. You would like to have it at 130. So you give an extra dose that is called the correctional dose of insulin, and you add that to the lunch Lispro. So you want to give a correctional dose of 4 units. So the lunch Lispro gets converted instead of 6 to becomes 10. So that is the correctional dosing. And because you gave that correctional dosing, you can see that the pre-dinner glucose has come back to normal. And when you write the insulin orders for the next day, try to include this correctional doses, especially if they're coming more frequently. Add the correctional doses in your next day's prandial dosing to make sure that you have a more perfect regime or more polished regime in the next day. Now, why do you want to use a analog, be it a basal analog or be it a prandial analog? Why do you want to use an analog? Basal analogs have more longer action, so you can manage with once daily insulin if you're using glargine or Tujo or Digludac or any of the longer acting insulins. They have got a more predictable insulin lowering and less variability, producing less hypoglycemia in hospitalized patients. Short-acting analogs are preferred for prandial coverage because of their faster action onset, faster lowering of postprandial glucose, and less hypoglycemia. This is how the difference acts. Like if you're using, compared to regular insulin, if you're using Lispro, you have the glucose concentrations coming to a baseline faster than when you're using a regular insulin. The 2-hour postprandial spikes are lesser with a prandial analog than with a regular insulin, and less nocturnal episodes when you're using Lispro instead of regular insulin. And with hospitalized patients, one of the challenges is that many of these patients require higher dosing of insulin or prandial dosing. And it is always good to use a more concentrated insulin, especially if your daily dosing of prandial insulin or per dose of prandial insulin is more than 15 to 20 units per dose. It is always good to go for a more concentrated insulin, so you can have a single pen being continued throughout the hospital admissions. Now, the final part is looking at the discharge management of these patients. This is in fact one of the most ignored parts of a diabetes management. So whether you are a physician in charge of a patient or whether you are an endocrinologist in charge of the patient, what generally happens is that your involvement in surgical patients may come in very late, or they may call you at the late stage and ask, okay, we are planning to discharge the patient tomorrow and please do something. So this is a challenge which we need to face every day. Now, in an ideal situation, you or your nurse or your diabetes educator should be sitting with the patient, reviewing the self-management concepts, and always remember that getting a patient in hospital, or I'd call it a captive patient, is the best person whom we can impart diabetes education and make meaningful changes in long-term management. When you put in a discharge summary, make sure that you give clear instructions on how to take insulin. Always good to have insulin teaching done prior to discharge if the patient is getting on insulin for the first time, or check the insulin technique. Make sure that you explain it in relation to the meals, in relation to the blood glucose monitoring. Explain hypoglycemia and how it should be managed, how self-monitored blood glucose reading should be kept, and how hypoglycemia should be managed if the patient is less able to do it themselves. Instruct one of the relatives to look at that, and always impart how this message of self-monitored blood glucose can be communicated to your team and subsequent dose adjustments can be made. So what is the protocol for discharge management? We have this RSDA recommendation saying how to go about for that. If you have a previously undiagnosed patient who is coming in with and detected to have diabetes, and you want to put the patient on a regime, if the patient is having an A1C between 6.5 and 7, and the patient does not require insulin on discharge, lifestyle modifications and metformin will be enough. More than 7%, and the patient is getting discharged and there is no immediate need for insulin, you can go for oral agents, and insulin is required, put on insulin with a consideration to convert it back to OADs on follow-up. Stress hyperglycemia, a follow-up, stress the importance of possible development of diabetes in the future and how lifestyle interventions can be done. And a patient with previously diagnosed diabetes on a previously reasonably controlled regime with an A1C of less than 8%, you could consider the previous regime more than 8%, consider intensifying OADs, or if the patient requires to move on to insulin, please do that. If there is no A1Cs available, in-hospital glucose is reasonably good. Pre-admission treatments can be reintroduced, or poor glycemic control, intensify the treatment. Which insulin should you send the patient back home? If the patient is eating normally, then most of his patients, as I told you, will be on basal bolus insulin. And when you discharge these patients, if the patient is eating normally, you could consider changing the patient to a premixed insulin, especially if the insulin requirements are not too high and the patient is eating normally, the patient is not anticipated to have a readmission or some other procedure coming up very in the near future. It is better to be on you could send the patient on a premixed insulin. But if the meal patterns are unpredictable, patient is not feeling well, the patient is not got good appetite, it's always good to continue basal bolus insulin for some more time and reassess the patient later. Just to show you two cases, and I'm going to close the presentation. The case one is a 46-year-old gentleman, type 2 diabetes, getting admitted with acute pancreatitis, baseline A1C is 9%, required ICU care, on IV insulin, changed to basal bolus insulin in the ward and getting discharged. What do you do? Case 2 is 52-year-old banker, on metformin, sulfonylurea, earlier type 2 diabetes for 3 years, A1C is 8.6%, admitted to the hospital for scheduled surgical drainage of an abscess, converted to a basal bolus insulin. What do you do? In the first case, just like Dr. Sujoy told, there is no right or wrong way to treat diabetes, but with an A1C of 9%, I would send this patient on a basal bolus insulin regime, see the patient back and decide what to do, because acute pancreatitis patients will take a bit of time to recover fully in terms of their eating habits. And if they had significant pancreatic beta cell dysfunction, then they may have very fluctuating blood glucose levels. For Mr. Sharma, I would consider going back to metformin and glimepiride, and because the A1Cs are high, consider using a basal insulin on top of this. Or if the patient has got a diabetes profile which is showing abnormal, significantly abnormal postprandial glucose elevation, I would consider the patient to go on a premixed insulin. Now, just to summarize the entire thing, hyperglycemia is extremely common in hospitalized patients. You need to look out for that. Good glycemic control, but not too stringent glucose control should be practiced. Insulin therapy is the method of glycemic control for in-hospital patients. And basal bolus therapy should be used in non-critically ill patient, insulin infusion in critically ill patient, and sliding scale alone is not a good strategy to use. Rapid-acting analog should be preferred over regular insulin in most patients, especially if they can afford it, especially for a shorter period of time, in view of the benefit side already shown and described. Thank you very much.
Thank you, Matthew, for that splendid lecture on initiating insulin in hospital patients. As you rightly said, there's a world of difference between patients who are getting it into the critical care and also those getting hospitalized to the wards with febrile illness or something else. If it is in a critical care, the patient is not conscious, or we are treating with pneumonia, which is with low oxygen cell with COVID infections, you may probably like to maintain the blood sugar just below 200 throughout the 24 hours. But on the other hand, if the patient is admitted to the ward with non-critical illnesses, then you have to be a little more, as you rightly said, a little more aggressive. Now, one of the things is that in critical care, when you're giving, suppose you're giving intravenous insulin, you may have to probably say that there is no difference at all when you give analogs or the ordinary insulin, because the regular insulin analog rapid actings do not make a difference when you give intravenous insulin. So that is one of the points for people who are taking care of patients in critical care. The other point is that when patients are getting admitted with illnesses in the hospital with high blood sugars and you start insulin, as you rightly said, this is the time they accept insulin as therapy for diabetes. And another thing is that those people who have never accepted insulin before the hospitalization get convinced about the efficacy and the ease with which insulin can be administered. And this is the time they will accept insulin as a good treatment for diabetes. And when you discharge, they're ready to continue the insulin and they'll get under better control. So the opportunity of hospitalization can be used to start good treatment of diabetes for a lifetime. Great talk. So we will have the discussion after the next talk. So we have the last speaker, and that is going to be Sanjay Kalra. And can you put the slide on to introduce Sanjay? Of course, Sanjay also does not need much of introduction. a much sought after speaker. He's an endocrinologist and has been very active. He's an executive editor of the Indian Journal of Endocrinology and Metabolism and editor-in-chief of the International Journal of Clinical Cases and Investigations. He also had prominent positions in medical societies, one of them being the rank of Vice President of South Asian Federation of Endocrine Societies since 2013. He's been an international speaker and has published more than 200 papers, both in diabetes and other non-diabetes endocrine diseases. So he's going to talk, I think his talk is also a recorded one. So he's going to talk on the rapid-acting insulin, recent advances on rapid-acting insulins. Can you put up his video now? Thank you.
Dear friends, as part of the centenary celebrations of insulin, today we'll be talking about recent advances in rapid-acting insulin. Especially, we'll talk about recent advances in high-concentration insulin and in precision dosing of rapid-acting insulin. These are my disclosures. I enjoy being part of the global fight against diabetes. And one of the strongest weapons that we have in the fight against diabetes is insulin. Insulin has come a long way in the past century. It was exactly 100 years ago that a young and brave doctor named Dr. Ed Jeffrey injected the first insulin into a child called Leonard Thompson. That was soluble insulin. It was rapid-acting insulin. But the purification was such that it would never cross the regulatory authorities' desk today. After that, there was a lot of evolution, a lot of improvement, and we began getting different types of preparations, different concentrations, and these preparations helped us create different insulin regimens. About 22, 23 years ago, we began getting insulin analogs. And the first insulin analog was actually approved and released in India when I was a DM student. So this webinar talking about the evolution of insulin takes me back to my student days. When we approach insulin, the student would be justified in saying that he or she is confused. But there's actually no need to get upset or get frustrated. We have a wide spectrum of insulin regimens, insulin preparations, insulin concentrations, and insulin delivery devices. The best way to plan therapy in the OPD is to first of all decide the regimen that you wish to prescribe. It may be basal, it may be premixed, it may be basal plus or basal bolus. Once you've decided that and you've agreed with the patient upon a plan of action, only then after that do you go on to thinking about which preparation to use. It might be human, it might be analog. And then after that, we decide the insulin concentration and along with that, the delivery device. If we follow this rule, mistakes will be minimized. But even to follow this rule, we need to have a fair idea of what we have available. In the field of prandial insulins, for example, we have regular insulin, aspart, lispro, glulicine, and fast-acting insulin aspart. So there are at least 5 preparations available in the country. All of them have a different structure. The mechanism of rapidness of action is different for all the 4 analogs. The pH is roughly similar for all except for regular insulin. The onset of action is slightly different for them. Regular insulin takes the longest time to act and it's the most inconvenient to use. The duration of action is fairly similar for all, but the injection meal time gap is different. The advantage that the analogs have is that you can inject immediately before or even immediately after a meal. And the risk of hypoglycemia is very low. High concentration insulins are also available now. We have high concentration insulins like U200 degludec in the West, U300 glargine in India, U200 Lispro in India, and we also have U500 regular insulin in some countries. Remember that for some high concentration insulins, like glargine, for example, the pharmacokinetics and the pharmacodynamics change to a fair extent. For others, like U500 regular insulin, the pharmacodynamics and kinetics change dramatically. So if you're using U40 or U100 regular insulin, you will use it thrice a day along with a basal insulin. But U500 regular does not work like fast-acting insulin. It works actually like a premixed insulin. And U500 regular insulin is usually prescribed twice a day, the same way you would prescribe a premixed insulin. Sometimes you can prescribe it 3 times a day as well. Along with that, you do not need basal coverage. But for Lispro, whether we use U100 or U200, the PK/PD remain exactly the same. The difference is, number one, in the delivery device, and number two, in the convenience to the patient. The delivery device that we have for Humalog 200, it's called Lispro Humalog 200 Quick Pen. This is much easier to use. The glide force that is required is less. The amount of volume that is required to ensure that a particular dose reaches the subcutaneous tissue is half as compared to what we have with the U100 pen. And if the patient is using 20 or more than 20 units of bolus insulin per day or Lispro per day, the drug is quite cost effective in this high concentration because the MRP is 25% less for the same amount of insulin. Let us see how we can use this practically in OPD. And to understand this, let's go through the story of Mr. Ram Ryan. He's had diabetes for the past 18 years, and he's had insulin for the past 18 years. Through these 18 years, he has experienced so many different insulin preparations, as you can see in front of you. He began with premixed human insulin. Then he didn't do well, so he shifted to basal plus using a human basal insulin, that is NPH, and an analog prandial insulin, which is Humalog or Lispro. So he started basal plus 1. Again, control was not good. So the doctor shifted him from the human basal insulin, that's NPH, intermediate acting, to long acting analog, glargine. Newer drugs were also added in the course of his illness, sitagliptin, and then SGLT2 inhibitors. But now he's still not fine. His HbA1c is 8.5. He is on basal plus, taking 2 injections a day, but the HbA1c is 8.4. He has hypertension and obstructive sleep apnea. His EGFR is 62. He is also on antihypertensives and anti-anginals. One complaint that he has is that he has to carry a large number of pens with him when he is traveling. So basal plus is not working for him because it is not effective enough, and it's not working for him because it's not convenient enough. And as we can see from his SMBG values, glucose levels are high throughout the day. Now you remember what we started with. The first thing to do is to decide the regimen. Based upon this glucophenotype in front of us, you can call it a glucophenotype, you can call it SMBG, you can call it a glucose profile, or you can call it glycemic personality. I personally like the word glycemic personality because it gives a human touch to our patient. Based upon this, it's quite easy to see that with this history of 18 years of diabetes and poor control of diabetes, what Mr. Ram needs is a change in regimen. So what should we do? Should we increase the dose of glargine or perhaps of Humalog before dinner? Keep the patient at basal plus 1, or should we change to basal plus 3, that is basal bolus? So what we did was we changed the regimen to basal bolus. We maintained the dose of glargine and we made the prandial insulin thrice a day. Earlier he was taking 10 units with dinner. We started with 6 at breakfast, 6 at lunch, and 10 at dinner. Now the first thing is done. We've changed the regimen. But now the next thing is the preparation. There was no issue with the preparations per se, with Glargine or with the Lispro, so we kept them the same. The third is the concentration. Now, since the patient is going to use 22 units of insulin per day and maybe using more, the patient was saying that it is inconvenient for him to carry a large number of pens. We can shift to high concentration insulin. And that is what we did for Lispro. We shifted the patient to Humalog 200, U200. With that, the delivery device also changed, and it's very welcome for the patient. He is 68 years old. The glide force required to injection is much less. So remember the hierarchy again. First decide the regimen, then the preparation, then we decide the concentration, and then the delivery device. You have to decide the initial dose, and while you're doing that, you have to remind your patient to understand the titration regimen, the SMBG regimen. When should the patient check glucose? Mr. Ram is not alone, because we find that nearly 2/3 of all people who live with diabetes and take insulin inject more than 20 units of mealtime insulin per day. Patients who had insulin for a longer period of time require higher doses of insulin. And in an Asian study, it was found that at the end of 24 weeks, the average dose of prandial insulin was 37 units. But if the patient had been using insulin much earlier, then the dose was 41 units. And these are the numbers that I see in my clinic as well. So for both type 1 and type 2 diabetes, we need higher doses of insulin. And if we can get the patient to take a high concentration insulin, where the cost is less per unit of insulin and where the convenience is more, it actually makes it helpful. Now, we said that the PK/PD profile for U100 insulin and U200 insulin Lispro was exactly the same. In spite of that, when participants were randomly shifted or changed to U200 Lispro, it was found that their control actually improved. Why was this so? The insulin is the same, the PK/PD profile is the same, the dose is the same. Let's look at the kind of participants that were recruited to this Italian study. 68% of them did have some kind of osteopathy, arthropathy, or myopathy. Nearly half of them had limited joint mobility. 12% had tenosynovitis and 21% had carpal tunnel syndrome. Some of us may find these numbers a bit surprising, but actually when you assess patients in the clinic, you will find that these diseases are really under-recognized, under-diagnosed, and under-treated, especially carpal tunnel syndrome and limited joint mobility. Also remember that a large proportion of your patients with type 2 diabetes, and especially with type 1 diabetes, will also have concomitant diseases like hypothyroidism, like micronutrient deficiency, and vitamin D deficiency. And all these actually will impact muscle and bone health. All of these also impact the ability, the dexteromotor ability of the patient to inject insulin, because a particular amount of force is required to press the pen. When these two groups were controlled, the Humalog 200 and the Humalog 100 group, it was found that the Humalog 200 group had less hypoglycemia, and they had less fasting glucose. They had less variability, and less dose was required. Less dose needed. In spite of that, the fasting glucose came down. Hypoglycemia also came down because variability came down. So overall, there was metabolic improvement. And what the authors suggested was that it's because of improved adherence and the fact that actually the entire injection, the entire insulin that has been prescribed is actually being delivered to the subcutaneous tissue because the plunger has been used properly. And the 20% decrease in insulin requirement that the authors reported suggested that another 20% reduction in cost is there. Almost all patients were very satisfied with their new pen. and they appreciated the decrease in injected volume, which led to a reduction in local pain and the reduced effort that was required. So this gives evidence to support the fact that we can use a high concentration Lispro device in patients on basal bolus or basal plus insulin, as long as their bolus requirement is 20 units per day. You can use it even in lower doses, but then remember that the opened pen has to be disposed of after 1 month, and there may be some loss of insulin. With the change in regimen and the change in concentration, Mr. Ram's HbA1c came down from 8.4 to 7.9. The SMBG improved. After that, we titrated the dose, and we were finally able to achieve an HbA1c less than 7. So using this new pen made our patient happy and made us happy as well. So to summarize, if we need to control postprandial glucose with Lispro, we can use a high concentration Lispro, especially in patients with high dose requirement, like those who are obese, those who have insulin resistance, because this helps us minimize the number of pens that we buy, reduces the volume of injection, reduces pain, and in general adds to subjective well-being. Now we've talked of high concentration. Let's talk of low dosage or precision dosage. There are many patients who are always at risk of hypoglycemia. The very young, the very elderly, those with low body weight, those with pancreatic diabetes or diabetes in pregnancy. In all such patients, precision dosage is required. Precision dosage is important because you will find many patients with brittle control. Brittle diabetes is not a term that we use very often these days, but it does exist in the clinic. Most of the times for me, brittle diabetes will be either when the patient is unhappy with my therapy, there are psychosocial issues that I am not able to overcome, or the patient has pancreatic diabetes, which I have misdiagnosed as type 2 diabetes. Remember that in pancreatic diabetes, both the alpha and the beta cell are damaged. Because the alpha cell is damaged, there is no glucagon to serve as a backup or as a barrier against hypoglycemia. So the moment you give half a unit or 1.5 units extra, hypoglycemia will occur. Glucagon cannot fight this hypoglycemia and patient goes into hypo. Then there is a rebound hyperglycemia. So that's why brittle diabetes occurs. In all such patients, we need precision dosage and we need to match the insulin requirement with carbohydrate intake. For this, we now have newer pens. The brand name is Humalog Junior Quick Pen, and this allows accurate and precise delivery of low-dose insulin. I use this in children. I use it in the elderly, frail elderly. I also use it sometimes in pregnancy. And in those who are at risk of hypoglycemia, patients with hypopituitarism, hypothyroidism, hypoadrenalism, all these are at risk of hypo. Patients with renal impairment, hepatic impairment, and gastrointestinal impairment, another 3 etiologies of recurrent hypoglycemia. In all such patients, I have begun using this half-dose unit pen, and this actually helps me titrate the dose accurately. For those who may feel that this has to be taken for granted, I would like to take you back 20 to 30 years ago. When I was a student in medicine, our titration used to be 5 units. So we would admit a patient in the ward, use bovine or porcine regular insulin, and give 5 units TDS. If the patient wouldn't get controlled after 1 or 2 days, the consultant would come and say, increase the dose. So then we'd make it 10 units TDS and then 15 units TDS. That was the kind of treatment we used to do. The results, I would be too ashamed to tell you what kind of control we had there. But now we don't do that 5 units and 4 units and 2 units anymore. Now we can actually increase or decrease in increments or decrements of half unit. And this will help us achieve good glucose control without causing hypoglycemia with minimum glycemic variability. so that we are able to achieve a good HbA1c. In all such patients, these new pens help. And these half-unit pens are actually relevant for a wide variety of patients. You can use them in routine patients as well. So today we have spoken about two newer developments in the field of insulin, especially rapid-acting insulin. We've talked of high concentration Lispro, and we've talked of precision dosage of Lispro. I hope that this information is able to help us improve the quality of care that we provide to our patients. Thank you.
Great. Thank you, Sanjay, for another brilliant, elegant lecture. And you talked about the high concentration Humalog as well as the low concentration precision pen using Humalog and their usefulness. So I think it has been very educative. So friends, we had 4 brilliant lectures. First, Dr. Ganpati Panpal discussed about the evolution of insulin and the history of development of insulin from the crude molecule to the refined molecules of today. And that after that, Dr. Sujay Ghosh talked about the initiation and intensification of insulin. He discussed about how premixed insulins are preferred by Indian patients as well as Indian doctors. And then Dr. Matthew John described about the hyperglycemic management during hospitalization, which is also a very useful talk. And lastly, Sanjay talked about the use of Humalog, both the concentrated Humalog as well as the precision Humalog. So we will now actually ask people if they have any questions, and then we will see whether we can answer those questions. To put across the first question to probably Sujay, I was just telling you about that there have been a number of studies comparing randomized clinical trials comparing premixed insulins with basal or basal bolus. And some of them have shown, of course, the outcomes were actually looking at the HbA1c as well as the insulin dose, weight gain, and more importantly, hypoglycemia. The study by, of course, Pashner and Matthew Riddle actually said that basal plus insulin are slightly better than premixed to prevent hypoglycemia. On the other hand, the large landscape study showed there is a neutral result. There was no big difference in as far as hypoglycemia, HbA1c, weight gain, or insulin dose is concerned, comparing basal bolus or premixed insulin. Of course, it also depends upon whether, as you rightly said, whether you start with one single premixed, 2 premixed, and 1 basal plus, or basal or multiple doses. So I think it has to be discussed between the doctor and the patient. And there are some patients in whom probably basal analog with bolus may be much more suitable, as you rightly said, the flexibility in lifestyle. In some patients, of course, premix may be much more useful. So I think you have to highly individualize the therapy of insulin to start with. Any questions on this? Yeah, you can comment.
I completely agree with you. All of these clinical trials that we are talking about, it very much depends on the population that has been chosen.
Correct.
Someone who's just failing basal therapy kind of a situation, of course, basal will be much better than, say, basal plus. And someone who's got very progressive, beta cell failure will definitely need prandial in addition to a basal insulin. And similarly, the more insulinopenic an individual is, there are so many factors that actually go into deciding what is better in a particular scenario. And I think, pharma companies have probably been very naughty in the way they design clinical trials and the way they recruit patients. You can almost tell that what the results are going to be depending on who the sponsors and who the designers of that clinical trial is. So I'm very skeptical when it comes to these insulin trials, and like you very rightly said, it's all treat to target studies. Therefore, you would expect A1C is going to be the same. So essentially, we kind of look at the insulin dose required, the weight change, and hypos, and then the hypos then get split into overall hypos, nocturnal hypos, severe hypos, and all sorts of things. I think ultimately the clinician has to look at the patient in front of him, understand his situation, discuss his convenience, and then decide upon the regime of insulin that you're going to start. So there's probably more of art of medicine rather than the science of medicine when we particularly use insulin.
Thank you. I think there's an Indian study called Nantes Plus finished from our center, which is a randomized controlled trial, which is multicentric, and the result will be published soon. And I absolutely, completely agree with what you just expressed. Now,
yeah,
yes,
Dr. Chamathan, yeah, can I ask you one question? It means although we typically educate our doctors saying that if your postprandials are high, then you go for a pre-mixed insulin, and if your fastings are high, then you go for fasting. But in clinical trials, is there any particular sort of glucophenotype identified which better responds to basal insulin or better responds to a prandial-based insulin? Are there any such glucophenotypes?
Good question. The answer to that is that when do you initiate the insulin? One of the reasons why we have got to use premixed or even multiple dose of insulin when you start or initiate insulin, intensive insulin in the Indian population is because insulin is started pretty late in the natural history of diabetes. In the Western countries, insulin started much earlier because the average HbA1c of people whom you initiate insulin is 1 to 1.6% higher in the in the Indian context compared to the Western population. So therefore, if you use a basal analog to start with and then fix the fasting, then you get a very good control because you also use oral hypoglycemic agents along with the insulin in the Western countries. So the answer to your question is the profile is depending upon how early you start. If you start very early, their fasting you get fixed with a basal analog, and the postprandial can easily be controlled with any of the doses of hypoglycemic agents that you use. So that is the profile that it is earlier initiation which makes a big difference. I hope I answered your question. Okay, you don't have Sanjay live on the program and not got him, right? Ganpati is live now, yeah. So how many people have logged in, Santosh or Hari? Can we have a number?
We have close to 95, sir.
Okay. Are there any questions coming in the chat box?
Only one, maybe not relevant to this, but treatment and precautions for pre-diabetes.
Oh, pre-diabetes. Who wants to answer that?
You are the best person to answer that, I suppose.
All right.
With your trial. Absolutely correct.
If you're talking about insulin pre-diabetes, the answer is different. If you're asking about treatment of pre-diabetes, the answer is entirely different. Of course, if you have pre-diabetes, what you're going to do is you're going to reduce the risk of getting diabetes, as well as you have to reduce the risk of getting cardiovascular events, because people with pre-diabetes also have a high risk of cardiovascular events. So the first thing is lifestyle modification. And the second thing is, of course, using metformin. As you know that in the Indian study, as well as in the American study, metformin have been used to reduce the risk of the development of diabetes and postpone diabetes. If you want to talk about insulin, there's only one study in which insulin was used in pre-diabetes for control of diabetes and to look for cardiovascular outcome. That was the Origin trial done by Sanofi, in which 12% of the participants who were recruited to the study were actually having only impaired glucose tolerance with a cardiovascular event. And of course, the outcome of the study was, the design was to actually see cardiovascular outcome trial for a period of it went up to 7 years. And it was a neutral study showing there was no difference between those who had normal plasma glucose with insulin compared to those who were treated with the standard therapy. But the difference in the HbA1c was only 0.3 to 6.2 and 6.3 at the end of 7 years. But the outcome of the study, more importantly, and the message of the study was that you can afford to start the modern basal insulin analogs in very early stage of type 2 diabetes, including pre-diabetes, and maintain an HbA1c of 6.2 for up to 7 years, reversing He's usually believed natural history of diabetes. So you actually prevent the progression of hyperglycemia and beta cell exhaustion by normalizing plasma glucose at an earlier stage in the natural history of diabetes by preventing the glucose toxic effect on the beta cell. Okay, so whether it's the insulin did it or the low blood glucose did this is a very difficult question to answer. I believe that normalizing plasma glucose has the effect. Whether you do with oral hypoglycemic agents, you do by lifestyle modification, or you do with insulin, that definitely preserves your beta cell for your lifetime. Okay, good.
Just
I should not be talking. I'm sorry, I should not be talking. I'm not the speaker here.
Just an extension to what Dr. Matthew initially asked. Most of the trials recruit patients based on the A1C entry criteria. Nobody looks at the fasting alone or a postprandial alone. And we all know that the A1C contributions by fasting and postprandial are different between, say, our subjects and a Western subjects. So how do you play out the difference between the basal versus a premix initiation, especially when you have so much of conflict about A1C contribution? Which does better? I mean, if you look at as what Dr. Sujoy said, the sponsor will decide what the outcome will be. So I want the experts to answer this.
Could I try and answer that? I would, in addition to the A1C, try to look at the glucose profile of that individual. That is clearly going to tell me what am I going to use as an initial insulin regime to try and target blood glucose levels. Like I said, when I was giving the talk, someone has a fasting of 200 and a post meals, all of say 230s, 40s. I know clearly by starting a basal insulin alone, I will be able to achieve glycemic control in such a scenario. Whereas if the fasting is 200 and the post meal is 350, no way am I going to achieve normal postprandial glucose control, even if I start only with simple basal insulin. There I have to think of something in addition of a basal component, which could be a co-formulation, which could be a basal bolus, which could be pre-mixed, which could be a basal plus. So depending on the initial glucose profile, I think I can decide upon, and of course, patient choice, his lifestyle, how rigid is his lifestyle. Personally, in spite of the fact that this is perhaps sponsored by Lilly, if I, for God's sake, have diabetes, I will go myself for a basal bolus insulin, because that gives me much more greater flexibility in terms of my lifestyle, the way I adjust things. If I'm skipping a meal, I'm not going to take the bolus. If it's going to be a delayed meal, I'm going to push it back. If I'm going to eat less, I'm going to take less of bolus. If I'm going to eat more, I'm going to take more of the bolus. So that's my take.
Yeah,
okay, what I will do is probably depends on the duration of diabetes also. Suppose you find that the duration is say 5 to 6 years, then I may just begin with the basal insulin itself. Suppose he's having say 15 years, then I'll prefer to use the premix. So that's one thing. Second thing is body weight also. Suppose he's overweight, though he may have 10 years diabetes duration, I feel he still has a reserve of insulin, and I could probably try with once daily basal insulin. See for some time, see your fasting is well controlled, and see you have still a reserve which could be able to tackle the postprandials. But then you find it's not coming under control, then maybe I will switch to a premix. So that's another thing which probably we can do.
So have they done in trials some sort of a subgroup analysis, like whether these guys respond better or these guys don't respond better in terms of fasting glucose high values? Because when you look at foreign speakers, they just don't think about premix insulin. They just say there are no glucophenotypes which will help you distinguish whether this patient performs well with premix versus fasting. Everyone does good with
paper is there, no? Your own paper on higher postprandial excursions for the same level of food, whether the Caucasians or Asians. So maybe premix is useful in Indians.
Yeah, that's what we believe, and we don't do it.
I would like to ask a question which is a little bit pertinent. So what is the concept of this panel about the use of either premix or basal bolus insulin along with the use of sulfonylureas? Because there are a clear thought that some people stop the sulfonylureas completely, some people do continue it. I would like the opinion from the panel. What do you people do? What is the thought behind that?
Will each of them give 1 minute to answer? Let's start with Matthew.
What I do is that for most patients, I actually keep the sulfonylureas on even when I start a prandial insulin, especially for patients whom we see that, say, A1C is around 8, 8.5 when I start insulin. I keep the SUs on. But if I'm going to start a prandial insulin when I have a SU plus an A1C more than 10, 10.5%, I just take it off because I realize the SU is not working anymore for the patient. That's how I do it.
Good. Yeah, Ganpati.
What I'll do is I will continue with the SU to begin with. And the next visit, probably I'll down titrate the dose to half of that. Suppose the patient is on, say, glimepiride 4 milligrams. The second visit, once the glucose has become better, I will down titrate to 2 milligram. If I feel it's reasonably controlled in the next visit, I will continue to keep the same. Unless the patient starts getting unpredictable hypoglycemias when I try to remove them off completely. Otherwise, that 2 mg may continue throughout. I just keep it. Yeah, I do agree with Matthew that more than 10, but then sometimes that I will continue to give it because if you stop it, it could further increase also. So probably I will continue that.
Sujay?
Right. If it's a basal insulin, basal supported oral therapy, the SU will continue. And had you asked me this question 2 years ago, I would have said I don't use SU at all when I'm using someone on prandial insulin because there was no evidence until about 2.5 years ago. Right now, there is evidence that if you keep the SU on, there are 2 or 3 publications which support it. But in actual real clinical practice, I do not continue the SU. I'm being honest about it.
I think you got the answers. Just want to mention here that when you talk about premixed and then I think basal bolus, and we're all talking about how to control the postprandial. But you look at the most important outcome. The most important outcome is to how to prevent hypoglycemia rather than reducing the postprandial blood glucose. Because hypoglycemia, even one terminal hypoglycemia, will definitely make the patient stop insulin completely. And secondly, undetected hypoglycemia, as you rightly said, can also affect the quality of life. So one of the most important outcomes is not just the HbA1c alone, but also the frequency of hypoglycemia. So I will vote for that prevention of hypoglycemia looks to be a little more important because you can wait and watch to achieve an HbA1c, but you cannot wait for preventing hypoglycemia. So wait and watch is a good principle. Okay, good. No questions? We have everybody's happy with all the speakers. I don't see any.
There is one question. Could you explain insulin corrective dose adjustment?
Who was talking about adjustment? I think
Sujay.
Yeah, Sujoy.
This is regarding insulin dose adjustment during?
I think Matthew.
I think it was by
No,
correctional doses. Yeah, I think correctional doses. Yeah.
Matthew,
I think,
correction doses. Yeah.
So I think this probably addressed more to the delegates. When you put in a basal bolus insulin, the sort of optimistic belief is that your sugars will be controlled at a certain dose, but the patients don't behave like that. Your fasting may be quite good. You may give a sort of prandial humalog in the morning, 6 units, and you expect your pre-lunch to be between a certain levels when you decide to give the next predicted dose of insulin, the sort of planned dose of insulin. But sometimes what happens is because of various reasons, the sugars may be higher or lower than what is expected. So when the glucose is higher than the normal target that you would keep, say you want it to be less than 130, and you see the patient is at 200, you will require some form of an extra insulin to bring it down below 130, and then for your regular insulin for your food. So this extra dose of insulin is what is called a corrective dose of insulin. Most of us do it based on our experience and based on patient characteristic that you can decide a corrective dose. But when the patient loads increase too much and you're not able to maintain it, you can always give a scale of how much correctional dose of insulin you need to add on to your prandial dosing. Suppose it is 6 units, as I showed you in the example, you need to probably add 4 more units so that you bring your 260 down to 130 and then the extra dosing for your food. That is the way I could explain it. If someone can word it better, I think I'm happy.
Well, correction dose is a good way of explaining that. And that's often done in all patients who are hospitalized.
The important thing is that whenever you see a lot of correctional doses coming in, it's important that you start modifying your actual doses so that correction doses become less and the actual doses are important. And as the patient recovers from the acute illness, then you may see that the doses keeps coming down. So it's important that your orders are reviewed on a daily basis. That's also important.
Good. I think we've done very well. If there are no more questions, we can probably wrap it up.
Thank you, sir.
Yeah,
thank you. Thanks, Professor Ramchandran, sir, and Professor Ganpati, Professor Sujoy, and Professor Matthew, and Dr. Kalra in absentia. So, for an excellent session in the morning, I mean, the first session of the day, and 100 years of insulin, and possibly all issues about what is the best way of starting insulin and then using, and all the issues concerning the insulin. We thank each one of you for your wholehearted participation. Thank you, sir. Thank you.
Thank you. Thank you very much, and good day to all of you.
Thank you. Bye.
Thank you.
Thank you, Hari, for the invite.
Thanks, Hari.
Thank you, sir.
Thank you. Bye-bye.
We continuing with the journey of diabetes per se, not the insulin. So we will move to the next session where we are going to discuss about the reversal of diabetes and then how best to initiate insulin. So to conduct and carry forward this session, we have two eminent chairpersons. I request welcome Professor Srinivas Murthy from Bangalore, and the other chairperson will be joining soon. Professor Srinivas Murthy is a senior physician at the Bangalore, and he's past executive committee member of API Karnataka chapter. He has vast experience in teaching both undergraduates and postgraduates, and a very, I mean, sought after name in most of the conferences. I request you to conduct further proceedings.
Thank you, Dr. Hari. And I've been following up the program. I think it's doing very nicely and it's on time. That's something I'm sure Santosh and Dr. Anantram are keeping a track of it. So let's move on to the next session. I think that's one of the commonest questions asked in our practice is, sir, doctor, somebody told us that diabetes can be reversed and we can get rid of medicines and injections, all that. Especially this become off late because of the keto diet in the Andhra and Telangana, just taken very popularly. I think Santosh knows it very personally also about these problems which he is going to face in his practice. And to answer these questions, which are very, very scientifically, we need to prove that that this is going to be correct method or what is the best method to reverse diabetes. And starting from the definition, I'm sure the topic will answer all these questions. And can we have the intro slide of the speaker, please? Dr. Hari, are we projecting the intro slide?
Yeah.
After Dr. Ravi. Yeah. So we have chosen the correct person for this because he's got various publications in this field, and also he's a practicing endocrinologist. That's something very, very important in a medical college in Berhampur. So that's something we want, sir, your insights into this, and please clear us the doubts, the air around this so-called reversal of diabetes. And over to you, sir.
Thank you, sir. I'll be just sharing the slides. So thank you, chairpersons and eminent faculties, and thank you, Santosh, for asking me. So this is, he has given me this topic, and very few days, the last 2 or 3 days, I made this slide. So I may not be entirely a vast majority, but I will try to answer some of the basic pertinent questions. So the first thing that comes to mind is when any practicing endocrinologist or a diabetologist, many of us come to this very question that patients come and ask, sir, the first thing they will ask is, do I have to take these medicines for entire life, or can it be reversed? This is, I think, I am sure that every one of us is facing day in, day out, and we are in a fix whether to taste or say something or what we have to answer in a scientific manner. So I will try to answer some of the issues which we face daily. Now, traditionally, what we have been taught is that at the time of diagnosis of diabetes, nearly 50% of the beta cell mass is already lost. And this continuing the decrease of the beta cell mass goes on inevitability. There is an inevitability to the beta cell mass loss. And by the age of, by the duration of 10 to 15 years, probably there is a 90% of the beta cell mass probably loses by age of maybe around 15 years. And 50% of the diabetic patients, type 2 diabetic patients, require insulin by 10 years of duration of diabetes. And it has often been said that beta cell apoptosis is inevitable. And what pathologically we have been told is the three main components. Of course, there are many more components. The three components, that is insulin resistance, insulin deficiency, and incretin deficiency. But nowhere have you ever been thought of reversal of diabetes, nowhere in the standard of care. You see the American Diabetes Association ADA guidelines, you see the ACE guidelines, you see any other guidelines, none of the guidelines ever talk about the reversal of diabetes as a standard form of care. So that's why we are more interested in controlling and managing the diabetes rather than in the reversal of diabetes. So what is first of all, let us be clear about what is the criteria for remission. The ADA in 2009 has said that if you are saying labeling somebody as complete remission, the A1C should be less than 6%, fasting glucose should be less than 100 milligram per deciliter, and at least 1 year's duration of absence of any of the pharmacological therapy patient might be was on. So this is what is labeled as complete remission, whereas the partial remission, we say that when A1C is less than 6.5%, and fasting glucose is anywhere between 100 to 125, and in the absence of pharmacological therapy. So whenever we are proceeding with any study or anything, we must be able to answer these questions and must be clear about this diagnostic criteria. Now the question is diabetes reversible? What are the evidences? So what I will be doing is, I will be very brief so that I will be present only relevant topics. I will not be present all the topics, all the studies. One is early intensive therapy in people with type 2 diabetes. This has actually come up in some years back, probably in 2010 to 13, 15 years, 2015. So there were many trials which were showing that early intensive therapy, 50 type 2 diabetes, probably they might land up in reversal of diabetes, maybe from few years, not for lifelong, for few years. Second is the bariatric surgery has come up in a long way, and the people have really thought of thinking of the role of diabetes reversal in people with bariatric surgery. Now, the third is low calorie and low carbohydrate diets, which one of our eminent speakers was actually referring to in the reversal of diabetes. So the moot question is, are they practical enough to be implementable in our day-to-day clinical practice? So this is what everybody is actually worried about. What is in the clinical trial? Can it come to the clinics? That is the question which I will try to answer. Now coming to the insulin treatments in the early part of type 2 diabetes, this is a short-term intensive insulin therapy in people with type 2 diabetes mellitus, a systematic review and meta-analysis by Kramer et al., which came in 2013. And these people were given an intensive insulin therapy for the first 2 weeks. And after that, they were stopped up all the drugs and they were followed up, these patients. And it has been seen that nearly 66% of the patients were not requiring any medication for till the 3 months of follow-up, which came down to 58% over 6 months, and 46% after 1 year, and 42% after 2 years of follow-up. So at 2 years of the follow-up, 42% of the people who were initiated with insulin at the newly detected diabetes, they were not requiring any form of therapy. The long term, beyond 2 years, this was not known what happens to them. Now, in this trial also, they have found that it also improves, pathophysiologically it is improved. The beta cell mass has also been, the beta cell function has also been found to be increased, and HOMA-IR or the insulin resistance has been found to be decreased. Now, this is another trial of short-term intensive insulin therapy in 48 patients with newly detected type 2 diabetes. and they were randomly assigned to intensive glycemic control for 2 weeks. And here, what they did is they gave the continuous subcutaneous insulin infusion, they gave the multi-dose insulin, and they gave the oral therapy also. So they were made 3 groups, and they followed these patients after 2 weeks. They stopped all the drugs and they followed these patients. And it has been found that nearly 21 out of 48 people were the reversal of diabetes, and rest 27 they were not showing any reversal. And if you compare the people who reversed and those people who didn't reverse, the HOMA-IR and the other parameters, they improved remarkably in people with those who have got reversal. Now coming to I will not go into other insulin therapy because there are so many, they are more or less showing the same thing for a short period of time. So I will not be going into details. Now come to the bariatric surgery on diabetes remission, a close look at the evidence. Now this is a this is a trial of sleep pass therapy, sleep pass trial, in which there were 121 people on sleep gastrectomy and 119 on bypass therapy. And these people were followed for 5 years, and you can see that the change in this by sleeve gastrectomy, the BMI has come down from 46.3 initially. It has come down after 5 years. It has come down to 36, and whereas in case of bypass, it has come down from 47 BMI. It has come down to 34.5, and it seems that the gastric bypass has a better control in the weight. Now come to what happens to the diabetes in these patients. So this is in the diabetes, if you see that there is a complete remission in people with sleeve gastrectomy by half a year, it was 18%, and whereas the gastric bypass, it is 23%. By the time it reached the 5 years, you find that 12% of the people in sleeve gastrectomy and 25% of gastric bypass, they were in complete remission. Similarly, if you see the partial remission, as I told you from according to ADA definition, the people who they were requiring almost 24% had the partial remission in sleeve gastrectomy and 20% by the gastric bypass. So it seems that the gastric bypass was showing in nearly 45% of people either partial or complete remission at the 5 years, whereas sleeve gastrectomy, it is almost 35% of the people who are in the remission. So this trial has shown that if you are, it is not initial studies, they have shown that up to 70%, 80%, there is a remission. But if you logistically see that at 5 years, it is only around 35 to 50% either partial or complete remission was seen in these patients. So long-term remission is a possibility with bariatric surgery till of course up to 5 years this trial has shown. Now there is another trial. This is known as the Stampede trial. This is a surgical therapy and medications potentially eradicated diabetes efficiently. So this trial recruited 150 patients, which are done into 3 arms. One is a medical therapy with 50 patients, a bypass of Roux-en-Y bypass in 50 patients, sleeve gastrectomy in 50 patients. And the inclusion criteria is the mean age is 49 years, duration of diabetes was 8.5 years, and the A1C mean A1C was 9.3 years. So at 5 years, what were the results? The results showed that the A1C has significantly come down in both bypass and sleeve gastrectomy from anywhere from 9.3% it has come down to 7.3 and 9.5 to 7.4%, unlike the medical therapy where the A1C has come down from 8.8 to 8.5%, only a difference of 0.3%. See the results of remission in these patients at 5 years. You find that nearly 45% of people on gastric bypass, they were not requiring any on any therapy, and in sleeve gastrectomy 25% they were not requiring any, compared to the medical therapy only 2% were only not requiring any therapy. And the number of drugs that are on these patients both bypass and gastrectomy, number of drugs has also come down significantly. Now, this is another Swedish trial, Swedish actually registry, anywhere from 2007 to 2015. They took all the cases and they found that at 5 years, it has been found that the complete remission has occurred in 46% of the type 2 diabetes, whereas partial remission is 12%, and some people were also on control on medications for 12%, and diabetes persisted in 28% of patients. So complete or partial remissions were present up to 58% of patients, either complete or partial remission was there. And it was also dependent upon the duration of diabetes. If it is less than 1 year, you find that nearly 80% were either partial or complete remission. As the duration of the diabetes increases, the remission rates, of course, decreases. So even if you try also, it should be done. It should be done very early in the part of duration of the diabetes. And there are various predictive factors who are going to remit. It seems that preoperative diabetes duration, baseline A1Cs, insulin treatment at baseline, age. So many things are actually predictors for this remission. Now, I will not go into any other further diabetes trials, bariatric surgery trials, because most of them are showing the similar rates of remissions. So how does bariatric surgery works? It works by various methods. One is immediate impact of surgery, calorie restriction, rapid emptying of nutrient into small intestine. You have removed a part of stomach in case of gastrectomy, or the other mechanisms where various gut hormones, microbiomes, with GLP-1, GIP, they all seems to be very much altered in these patients, and also effects finally leading to improving the beta cell function, improving the insulin sensitivity, and reducing the hepatic glucose output. Now, come to the other point of view. This is the reversal of diabetes in patients with those who are other than any other mechanism. So this is a counterpoint trial. It is one of the remarkable trials which came in diabetology in 2011. And they took 11 patients with type 2 diabetes with mean age of 49 years, BMI of 33, and they gave the very low calorie diet. That was around 600 kilocalories plus non-starchy vegetables or salad was given. And these people were followed for 8 weeks. And at 8 weeks, there is a remarkable decrease in weight of almost 13 kg. There was decrease in weight. So, and the A1C levels have come down from 7.4% at baseline to almost 6.5% at week 4, and plasma glucose levels from 9.2 millimoles to 5.7 millimoles. C-peptide has also been improved. Come to the terms, you can find that there is a significant decrease in the fasting glucose. There is a hepatic triglyceride. This is very important. Hepatic triglycerides have come down from 12.8% to 2.9% by 8 weeks. And pancreatic triglyceride has come down from 8% to 6.2%. And the more importantly, the first phase insulin response has been restored. So this is the first one trial which has given the Pandora's box that if you reduce the calories, it can reverse the diabetes. It's a very short-term trial of 8 weeks duration. So the hypothesis was that pancreatic beta cell function and hepatic insulin sensitivity, they can be restored with a diet with calorie restriction. So this has opened up the Pandora's box, and this is a twin cycle hypothesis that has been proposed for this. So one is whenever somebody takes a positive or excessive calories, which are likely to be deposited in the liver, which is predisposing to insulin resistance, which causes again hyperglycemia, and which causes further insulin release, leading to further accumulation in the fat, releasing the more triglycerides, which are likely to affect the pancreas. So it is a vicious cycle. So this is a twin cycle which has been explained to answer this question. Now, based on the counterpoint trial, a counterbalance trial has been undertaken. This is again also, this is not 8 weeks, this is 6 months trial in type 2 diabetes on the pathophysiological changes in the responders and non-responders. These are 30 patients were there in type 2 diabetes and age group 25 to 80, BMI of 27 to 45. The duration of the trial was 6 months. 3 phases were divided. Very low calorie diets, 624 to 700 calories given for 8 weeks. Then they changed to isocaloric diets for 2 weeks. Again, they changed to the normal previous diet. They changed, and weight maintenance program was continued for 6 months. And at 8 weeks, they found that 40% of the people who were having fasting glucose of less than 7 millimoles per liter, these are termed as the responders. So they try to analyze the responders and non-responders. And you can find that weight has come down remarkably in these patients. In the responders from 99.8, it has come down to 84.84. And the BMI also has come down. Triglycerides have also improved in this trial. Now, what happens to the A1C levels and reverse in these patients? You find that fasting plasma glucose, the difference between the responders and non-responders was 10.9 in case of non-responders, 6.2 millimoles per liter in case of responders. A1C has come down in the responders from 7.1 to 5.8, which is almost normal, less than 6% has come. Whereas in case of non-responders, it is 8.4 to 8%. Of course, the weight has come down. The first phase insulin response has been restored in case of responders, and pancreatic triglyceride has come down remarkably in patients with responders. So based upon the counterpoint trial, this counterbalance trial has been undertaken, and it seems that reversal of diabetes occurred in 40% of diabetic patients, and with the duration of diabetes in these patients less than 4 years was the almost 60% were there in the study. Then another trial in 2013 it came as the look ahead trial. There are many components were there in this trial. One of the components is intensive lifestyle management in this patient. This is a large trial with nearly 4,500 people completed for 5 years. Again, in this trial, there was a calorie restriction was there, but it is not as severe as that in other trials. It is around 1,200 to 1,800 calories per day, followed by the intensive counseling, initially weekly, then followed by monthly, then physical activity 175 minutes per week. And the other group is the diabetic support education. They were given only diabetic support education twice a year. And you can find the results. You can find that at 1 year, 11.5% were in remission, 2 years, 10.4%. By 4 years, it has come down to 7.3% of the patients. They were having the remission, either partial or complete remission. So remission is a possibility in set of patients who are likely to have the short duration of diabetes, who are having the less A1C levels, and those who are younger, those who are likely to remit in these patients. Now, can it be applicable to the in our primary care, what we are seeing in a clinical based, whether it can be applied in this or not? So the direct trial, which is to answer from UK, to try to answer this question. So what they did is, this is an intervention trial involving 149 patients of intervention group, control also 149. The inclusion criteria was again the same, but the duration of the diabetes was less than 6 years they took. And what intervention they did is, they gave the formula food, which is around 825 to 853 calories for 3 to 5 months they gave. So instead of giving for 8 weeks, they gave for 3 to 5 months. And then there is a step reintroduction of the food over 2 to 8 weeks, then the support for weight loss for 1 year. So initially there is an intensive management, then followed by this thing. And what we find is, we find that there is a 15 kg weight loss has occurred in 24% of patients compared to control zero group over the year of 1 year. And the reversal of diabetes was 46% at 1 year compared to 4% in the control group. And the reversal has occurred based upon the weight loss. Less than 5 kg weight loss, 7%, and 5 to 10, 34% increased to 56% by 1 year in people who have lost 15 kgs weight. And also there is a significant decrease in the A1C levels of minus 0.9%, and all other parameters also, some of the parameters, of course, they improved. Now the question is, can it be applicable? It is only for 1 year trial. So another trial, the same trial, which has been extended for 2 years, and you can find that what was initially 24% of remission, by 2 years it has come down to 11 point, sorry, this is for weight loss, 15 kg, 24% to 11.4%. And the reversal of diabetes from 45% to 35%, it has come down, but still it is a decently, people were having up to 1/3 of the people were having in remission by 2 years. And you can find that according to body weight, and even at more than 15 kg people, nearly 80 and 70%, they were still in remission by the 2 years. So this is one trial where it has shown that even in a primary care also, we can achieve this if we are equally motivated enough for the patients. Now, another trial, this is a piloting the remission trial in patients with diabetes. See, what we are doing in the initial trials, the direct trial and all, they were based upon the diet. So this trial wanted to give a drugs actually for an intensive group and see what happens to in this case. So this is an intensive metabolic control has been attempted. 83%, 23 is the BMI, A1C less than 8.5%. Duration of the diabetes was less than 3 years. So 8 weeks group, they started with insulin glargine, metformin, and acarbose. And there were two groups were there, one 8-week group, the other one is 16-week group. In both the groups, similar thing has been attempted. Similar group has similar drugs have been given, and a control group of standard therapy, and followed 12 weeks after stoppage of all these drugs. You find that in the 8-week group, in the 8-week group, after stopping for 12 weeks all the drugs, you find that 21% were in remission, partial or complete remission, compared to 16-week groups. You find that nearly 40% of the people were in partial or complete remission. So, by 3 months after stopping these drugs, even the intensive therapy, they were seems to be in remission. Now, this is another trial. What actually initially the person was trying to point out that one is the low carbohydrate ketonic diets versus moderate carbohydrate calorie restriction diets. This is a 1-year trial. So what they gave is usually these ketone diets, usually they give it calories, they give the carbohydrates less than 50 grams. So they gave 20 to 50 grams of carbohydrate and add become intake, and they were measured the blood ketones to ensure that ketosis occurs. 0.5 to 3 millimoles per liter was the blood ketones, and then of course the physical activity was continued. And in the other group, the moderate restriction group, there is a 500 kilocalories less than the what usual intake, and 40 to 50% of the calories come from carbohydrate, and of course the physical activity was there. So what they achieved is, of course, the A1C has come down from LCK group from 6.6 to 6.1, and in the moderate carbohydrate restriction, there is a 6.9 to 6.7%. There is also some improvement in the body mass index, of course, body weight is also reduced. Now, come to the reversal of diabetes, or less than 6.5 A1C, these people, at 12 months, you find that nearly 77% of the people on the LCK group, they were having the A1C of less than 6.5% compared to MCCR group, 30% was this one. So in this group, all other drugs were stopped. So it was supposed that probably it is in a short-term trial of 1 year, it is showing that there is definitely a low carbohydrate group as showing that some improvement in the remission rates of diabetes. So this is the latest meta-analysis which has come in this year, January, in BMJ. Efficacy and safety of very low carbohydrate diet for type 2 diabetes remission, a systematic review and meta-analysis involving nearly 1,357 type 2 diabetes patients. They found that if you give it for 6 months, it has been found that there is a 32% increase in the remission rate in people with low carbohydrate diets. But over a period of 1 year, this remission rate has come down to 0.05%, which is not very significant. So in a short-term trial of 6 months, it seems to be it is showing the reversal of diabetes in this type of patients. So now to conclude, I will not take much time. So the diabetes reversal is a possibility. Early diabetes, especially duration of diabetes less than 4 years, likely to be, you can attempt, of course, and early intensive phase of calorie restriction shown in the direct trial. It gives a hope for long-term diabetes control, at least in 35% of patients over a period of 5 years. So direct trial has also shown that it can be practicable at a primary care level. So how can we reach in a setting like us? How far it is practical? Of course, I'm not so sure about it, but it is one way of looking at it, and it requires a lot of motivation, follow-up, and proper guidance. I thank you all. Thank you.
Thank you, Dr. Ravikumar, sir. At the outset, my sincere thanks to Dr. Santosh, my good friend, for giving me an opportunity to be amongst you people. And it was once again an excellent lecture. When Santosh asked me to chair, I thought that the topic is so interesting that I should be a student rather than chairing the session. And truly, Dr. Ravikumar sir has enlightened us quite well. Though all of us have some real-time evidences in terms of reversal, because as a practicing internist, I keep on referring cases to the surgeons, especially with regards to the bariatric surgery. And the results are astounding. We have a good number of cases where we could reverse the state of diabetes. And Sir has already come out with good bit of RCT trials, and together, I think with the real-time evidence is building up, we can offer this as an opportunity, and it would definitely be a sort of an encouragement for the patients. And the second session probably would be dealt by Dr. Manoj Chabla from Mumbai. It is something which is an extension to this topic. Early treatment and intensification would help in beta cell proliferation. I think we'll take up the QA sessions after this session, sir, with the consent of my co-chair, Dr. Murthy, sir.
Sure, sir. Sure, sir.
Yeah. Dr. Manoj Chabla is the director and consultant diabetologist at Leena Diabetic Care Center and Mumbai Diabetic Research Center, Andheri. He's also a consultant diabetologist at Asian Heart Institute of Research, founder president of United Diabetic Forum, UDF, honorary visiting faculty at DY Patil Medical Sciences, Navi Mumbai. And he was awarded the RSSDI Fellowship for the year 2017 and Fellowship of Royal College of Physicians, Edinburgh for the year 2019. He's the PI for various global multinational clinical trials, including the devices. He is also a course trainer in the National Diabetic Education Program, an initiation by Dr. Mohan. So lots of credits to Dr. Manoj. We look forward to listen to you. Over to Dr. Manoj.
Thank you, Dr. Shrikant and Magna Endocrine Update, Dr. Santosh, for inviting me, and it's wonderful to see some senior colleagues here this morning. Let me start by sharing my screen. Right. And my topic today is early treatment intensification and beta cell function. My disclosure is that I have a speaker contract with Novartis for today's talk, but I'll still try and make it as neutral as possible. The outline of today's talk is the guideline shift that we have seen, standard conventional management that all of us were used to today's belief in early intensification, the importance of early treatment intensification, moving on to focusing on the landmark Verify trial, giving an overview of the same, the data which we got later about the beta cell function improvement in Verify trial. Are Asian patients different? Is there a difference in the way we respond to the oral anti-diabetic drugs? Then looking at the sub-analysis of the Verify, the Indian data, and finally to show some data from the initial study, which is very, very close to my heart for reasons that we'll see later. The guideline shift, the standard conventional management has moved to early intensification. And if you see even the ADA-EST consensus reports over the last 3 years, 2018, it still stated that there's little evidence for initial combination therapy, that it's superior. So, hang in there, go slow. By 2019, the ADA-EST consensus says providers should engage in shared decision-making around the initial combination therapy. So start considering them, have a discussion with your patient. And 2020 onwards, there's been a clear guideline that early combination therapy can be considered in some patients at treatment initiation itself to extend the time to treatment failure. So that has been the concept. And largely, this has been driven by the fact that we have drugs today which we can use for early intensification without increasing the side effects, without increasing the chance of hypoglycemia, something which seemed to be a limiting factor in the past, that really should we go aggressive, should we be intensive from the beginning? There is too many side effects that the patients can experience. Once that has changed, that has led to the guidelines changing. So the importance of early treatment intensification, well, early intensive glycemic control clearly shows the benefits of delaying the deterioration of glycemic control. So the earlier you control, there is clear data that the worsening would be prevented. It achieves glycemic goals earlier rather than the stepwise manner, and you keep and wait and watch. And there also data that this initial good intensive control may have better preservation of the beta cell function. So these are some of the greater clinical benefits which have been observed with earlier early intensive glycemic control. The impact of early and appropriate intervention may improve patients' chance of reaching the goal. So all of you will agree that in the past, we've been doing the typical stepwise approach. Everybody told us that don't be aggressive, you should give sufficient time with diet and exercise. But I still think it's important that you do that. But along with diet and exercise, and we know the percentage of patients who fail just with diet and exercise or who are not motivated enough for the same. So along with that, then in the past was that you go slow, use one drug, typically metformin, increase the dose the patient can tolerate, patient fails, then you move from one drug to a combination and eventually to insulin and multiple shots and so on. But today, we clearly realize that in doing that, we are missing out on that very important period of the first few years post-diagnosis of diabetes. And unless you are having your patients under control there, the impact towards worsening of complications, worsening of control, or rather getting more and more difficult to control your patients later on in life because you missed the opportunity to control them well in the beginning years is getting more and more evident, and there's stark evidence glaring at us that we did things wrongly in the past because we were not aware or we did not have options to that extent. So that's where the things are changing, as shown in this animation, that you really want to use safe combinations from the beginning, get your patients to target right within the first 6 months or year of diagnosis, and keep the patients there as far as possible. Now, we always speak about the landmark UKPDS data, and all of us know the findings from UKPDS. What did it tell us? That achieving early intensive glycemic control would generate a good legacy effect. So you call it good metabolic memory, you call it a good legacy effect. Clearly, the difference between the conventional and the more aggressive arms in terms of reduction in the initial glucose levels, today we know the benefits extend even beyond. Once the UKPDS ended and the patients were then left without monitoring, we know a couple of years later, the HbA1cs became more or less similar. The patients were on their own. But when they were followed up, even 10 years after the UKPDS study ended, there was clear evidence that those patients who maintained more intensive control in the beginning years still had 24% reduction in microvascular complications as compared to the conventional group, 15% reduction in MI, and 13% reduction in all-cause mortality. So again, a great learning for us that we should not let go of the opportunity in the first few years after diagnosis. Also, early treatment intensification has shown that it leads shorter time to glycemic control. So when you talk about the time to first glycemic control, within 7 years after intensification stratified by time to intensification, you clearly get to see that the median time of intensification to control for those who came to control early was 20 months as compared to 24 and 25 months in those where you had late control, intermediate or late control. So concluding that the likelihood of attaining glycemic control was 22% and 28% lower for patients in the intermediate and late intensification groups, respectively, as compared to the intensifying early group. Decline in beta cell function with type 2 diabetes severity and duration. So here, well, this is what we look at, the Starling's curve of pancreas, if we can call that. There is going to be a continuous decline in the beta cell function. And as there is continuous decline in the beta cell function, that is the reason that why our stepwise approach of doing this lifestyle first, monotherapy, dual therapy tends to fail. In the past, we've been treating to failure. We waited for the failure to happen and then treat, not realizing that there is a gradual decline in beta cell function in our patients with type 2 diabetes, which is bound to happen. So hence, we need to move beyond the traditional sequential approach. Now, anti-diabetic therapies and beta cell function, well, some of these drugs have shown great evidence that if used correctly, they may actually improve the beta cell function. Especially the glitazones, insulin, of course, and incretins have direct effect on the beta cell function. Both the glitazones and incretins, they have evidence of reduced beta cell apoptosis. One may argue these are more in animal studies, but yes, yet they have shown some evidence there. They promote some beta cell proliferation. There is evidence of increased insulin synthesis and secretion by these drugs, and of course, improved insulin secretory patterns. So various studies have shown that the use of these drugs can actually benefit our patients, and we should offer them much earlier on. So I move on to the verified trial. Let's look at the overview of the verified trial. Now, how was Verify different from all the various trials that we've done? And we're talking about the earlier traditional trials, which only had the intensive and conventional arm, be it UKPDS, be it advanced, VADT. All of them typically have patients in two groups, which was intensive versus conventional control. Before we moved on to looking at the cardiovascular outcome trials, which was completely different. But all of these patients all of these trials had patients who had diabetes duration for a while. They also had patients with risk factors in the cardiovascular outcome trials. As compared to this, for Verify, it falls much before. So these are patients in the early years, absolutely early years of their diagnosis, essentially drug-naive patients. So you had somewhat a similar population in UKPDS in the early years, but again, also in ADOPT to some extent, but yet none of them fall in the place where Verify is, which is patients with an HbA1c between 6.5 to 7.5, and in the absolute early years of their diabetes. So completely different trial, looking at a paradigm change in our thought process and our approach. A multinational and multi-ethnic studies, 34 countries, 254 centers, more than 2,000 people with reasonable representation from Asia and India also. The study design, well, the objective was to assess the long-term clinical benefits of early treatment intensification with the vildagliptin-metformin combination compared with the usual standard of care, which is just metformin in drug-naive patients with type 2 diabetes. A randomized, double-blind, two-arm parallel group study consisting of a screening visit, a 3-week run-in period, and then the entire treatment period with a primary defined failure threshold, which was HbA1c less than 7%. This was conducted over a 5-year treatment period during which patients' treatment was consecutively intensified if clinically indicated. And that meant if they had more than 2 HbA1cs staying above 7%, each HbA1c being 13 weeks apart, then they would be intensified to the next stage. So again, let me explain the study design. Well, post-randomization in the period 1, you had in one arm patients on vildagliptin and metformin, the early combination. The other arm was metformin plus placebo. These were double-blind studies and hence the placebo there. Patients then entering into period 2, those who failed to stay, they would stay on the combination yet, and those in the metformin arm who failed would move to the combination. So in period 2, you had both the arms now move to the combination, especially those who had failed in the metformin only arm. And yet ahead, beyond the 12 months to a longer period, and patients failed on this when they could not maintain their HbA1c at less than 7% on 2 consecutive readings, more than 13 weeks apart, then they would be intensified to insulin. So that was the study design. The baseline characteristics were largely similar globally. I'm looking and focusing at the East Asian population, which is where the average age in this study was about 52.9 years. HbA1c was 6.9, fasting sugars 7 millimoles. You had 12% as smokers, and average BMI in this study was 26.9. Seems a little higher for the Indian population as an average, but this was all over East Asia, and this was the baseline characteristics. We look at the results, and this is where it all starts getting clear. So when you talk about the time to initial treatment failure, which is the time that the initial treatment failure was the time that the patients would not respond either when they were on the combination therapy or on the initial monotherapy. So the time to initial failure, treatment failure, was 36.1 months in the metformin group as compared to 61.9 months on average for the metformin and vildagliptin group. So it's almost double if you look at that. You look at the secondary failure, that means patients who would then have moved on later on to the insulin, again, you get a hazard ratio of 0.74. That means 26% relative risk reduction in the early combination group as compared to the initial monotherapy group. Now, what are the clinical implications of this significant data from Verify? The median time to failure was 3 years in the initial monotherapy group compared to over 5 years in the combination group. When all patients were receiving the combination therapy, both the arms had come, the risk for time to second treatment failure, which was use of insulin, was reduced by 26%. Both approaches, of course, were safe and well tolerated, but the early combination treatment, half the risk of time to initial treatment failure versus monotherapy strategy. So the strategy of an early combination with vildagliptin and metformin in patients with newly diagnosed type 2 significantly and consistently improved the long-term glycemic durability compared with metformin monotherapy. So today when we talk about drugs, we know that each drug fails. We want to talk about the durability and verify clearly showing that in drug-naive type 2 patients, the combination found to be far more durable, leading to less time to intensify, whether it was initial treatment failure or secondary treatment failure requiring insulin. Now let's look at the data for the beta cell function in the verified trial. So they looked at changes in beta cell function, which were assessed by the HOMA models from baseline to the confirmed initial treatment failure. HOMA beta was calculated using, as we understand, fasting insulin and plasma glucose levels. 2,001 patients enrolled. Of this, 1,003 were in the monotherapy group, 998 in the combination therapy. A segment of those patients were assessed for the HOMA beta, 747 in the combination and 676 in the monotherapy period. What did the results show? Well, change in HOMA beta from the baseline to confirmed initial treatment failure. You clearly see here the change in HOMA beta from baseline. In the monotherapy group, you actually had the decline in beta cell function as compared to improvement in the combination therapy, leading to a difference of 19.23 between the two groups. So again, driving home that strong point that not only are you controlling your patients better, but the initial combination therapy of vildagliptin and metformin is also leading to protection of the beta cells. It's improving the beta cell function, and this is going to have its advantages in years to come as the patient continues to respond to the existing therapy. This concluded that early combination with vilda and metformin in patients with newly diagnosed type 2 diabetes showed improvement in beta cell function compared with metformin monotherapy and consistent with the improved glycemic control and durable A1C response observed in the VERIFY study. We now move on to look at the data of the oral anti-diabetic drugs in the Asian population. We've always commented and said that every drug or every data that we get about a drug from the Caucasian population or the Hispanic population may not transpolate into what we see in our Indian population or the Asians at least. So it's time now that we start looking at how drugs respond differently. Why? Because the Asian phenotype is different. There are challenges associated with achieving optimal glycemic control in Asian Indians. There is more insulin resistance. There is increased abdominal adiposity, reduced levels of adiponectin, high levels of hsCRP, increase in leptin, increased insulin sensitivity index, reduced acute insulin response to glucose, whether it is the first phase insulin response or the overall initial response is much delayed and slower, and the problem with early loss of beta cell function. So all of these problems would lead to relatively early loss of beta cell function. This may need early use of insulin-providing therapy. So just using metformin as an insulin sensitizer may not suffice. We largely have reduced beta cell function, that is the Indian population as compared to our Western counterparts, and hence we on metformin tend to fail earlier. A large number of patients tend to fail on metformin, and it's only that we'll end up losing those initial crucial years by sitting quiet and giving them only metformin monotherapy. The effect of incretin-based therapies in Asians versus non-Asians, and this is where the data came in. And I'm sure all of you remember a decade and a half back when the DPP-4s first hit the Indian market. We were also given the data that this is going to work about 0.5, 0.6%. At that point in time, each DPP-4 was expensive. We started thinking, really, is it going to be worth it? All of us started offering this as a third or a fourth drug before insulin. And then to our surprise, we saw great response in glycemic efficacy, and our patients started responding to DPP-4 inhibitors much better than any evidence which came to us from the phase 3 studies from the West. And this is again evident in the two Asian studies by Park et al. And Kim et al., where they clearly show that as compared to non-Asians, the HbA1c reduction was far more, 1.67 as compared to 0.65 in the Park study, 0.92 as compared to 0.65 in the Kim study. So clearly better glucose-lowering effect of DPP-4 inhibitors. Glucose-lowering efficacy of drugs is based on ethnicities. This is a wonderful meta-analysis by Gann in 2020, which saw that beta cell deficiency has been reported to be a feature of Asian diabetics. And what they found was the glucose-lowering efficacy of both these group of drugs, DPP-4s and SGLT2 inhibitors, seems to be much higher in patients with predominantly Asian ethnicity as compared to the white ethnicity. However, they could not find the similar data or results for GLP-1 receptor agonist-based therapies, but it was predominantly for DPP and SGLT2s. We now move to looking at the Indian subset analysis of verified trial, the data from home. Of the total number of Asian participants in the global verified study, 47% were Indian. So we had 163 patients of these patients in the study, about 2,000 patients. The verified baseline characteristics in India, And this was pretty uniform. Whether you look in the monotherapy group or early combination group, you had more men than women. The age was about 48 on average. HbA1c at baseline was 6.8. To remind, the inclusion criteria was 6.5 to 7.5. You had a BMI of about 27 in the Indian patients, and you had normal baseline GFRs of 75 and 65, and about 3.7 and 6.2% smokers. And initial treatment failure. So we saw the global data. Now let's look at the data in Indians. Did it score differently? In fact, there is evidence that it did even better. So the incidence of initial failure, patients' percentage with an event as compared to initial monotherapy, in the combination therapy, it was 43.2% as compared to 59% in the monotherapy. So early combination treatment significantly reduced the relative risk of time to initial treatment failure by 53%. And as clearly seen here, Vilda plus metformin scoring much better than just the metformin and placebo group. Median time to initial treatment failure, 50% patients failed in the metformin monotherapy group at 1.5 years versus those on the combination group who could go on for 4.75 years. And that's my strong belief also. Believed in that before seeing this data, and it's been further enhanced that metformin responders in our population tend to be very few. So just metformin, which is a great drug and its benefit should be given, but it just requires the support of another good drug like a DPP-4 inhibitor here. So again, median time to treatment failure for early combination was much, much longer, 247 weeks as compared to 78 weeks in the initial monotherapy segment. And to second treatment failure, well, so that again, when you look at these groups, the fact that you've been able to give the benefit of metformin and vildagliptin in the beginning as compared to only metformin alone, the secondary treatment failure, which was initiation of insulin, again, you have a hazard ratio of 0.42. That means 58% relative risk reduction in favor of the combination as compared to metformin alone. Success rates between treatment approaches, amount of patients who could achieve HbA1c less than 7% throughout the spectrum of this 5-year study as compared to early combination, the initial monotherapy showing patients staying at less than 7% to be much better. The key findings from the Indian subgroup, early combination treatment, half the risk of time to treatment failure versus monotherapy strategy. Median time to initial failure was 1.5 years in the initial monotherapy strategy compared to almost 5 years in the combination strategy. So 1.5 years as compared to 5 years, that's a huge difference. Both treatment approaches were well tolerated, and when all patients were receiving combination, the risk for time to second treatment failure, which again, I keep repeating was insulin, was reduced by 58%. So these should have actually transformed into us being convinced about the benefit of an early combination. As I said, in the past, we were afraid of being accused. Are we too aggressive? Are we using too many drugs and offering this to the patient rather than focusing more on diet and lifestyle? No, we should all continue to focus on diet and lifestyle, but clearly evidence with the new safe drugs makes it imperative that we offer the combinations much earlier to our patients. And this would be the clinical implication of these studies, especially the data from India, which is telling us that long-term clinical benefits can be achieved more frequently without tolerability issues in our patients. And that should be the advantage given to the patients. Quickly moving on to the initial study, and I'm thankful again to be the principal investigator and author along with some other Asian colleagues. This was a 4-country study. This was a real-world data. So sometimes we want to see more closely the real-world data as compared to a randomized clinical trial, which is more controlled. So this was again in drug-naive patients with type 2 diabetes with an HbA1c of more than 8%. More than 8% was the Indian requirement by the Indian DCGI. In the other Asian countries, this was 7.5%. You had the baseline visit. You had a visit at 12 weeks and 24 weeks. So a simple observational study there, where patients who were put on to vildagliptin and metformin as a part of routine clinical practice on these combinations were followed up at baseline 12 weeks and 24 weeks, having a look at their HbA1c, their fasting, postprandial, their medications, adverse events, body weight, etc. What did we see? That in terms of the patients who had their age less than 65 years, 95% of the population had their age less than 65 years as compared to 10% population which was over 65. The data from the initial study was again impressive, and this tells us actually the numbers which many of us see in clinical practice, but we don't see them in the RCTs. Significant HbA1c reduction at 12 and 4 weeks with vildagliptin plus metformin in drug-naive patients. So if you see the overall population, At the end of 12 weeks, you had 1.6% A1C reduction. And then by the end of 24 weeks, you had further 1.9% reduction. Now, if you look at the subgroup, which was the high baseline A1C, so there were a significant number of patients who started with a high baseline A1C, more than 10.5%. In that group, the average A1C was 11.7, and you see a 3.3% reduction A1C at the end of 12 weeks and 4% reduction at the end of 24 weeks. Now, very few studies show this. And the fact is, these are drug-naive patients. You've been able to use a combination right from the beginning, especially patients who have started with a high A1C. Those who are not metabolically decompensated today may not always require insulin that A1C when they are drug-naive. You use this combination along with diet and lifestyle, and you're seeing significant reduction in HbA1c in a lot of these patients across Pan-Asia. The take-home message: beta cell deficiency has been reported to be a feature of Asian diabetes. We need to keep that in mind. Incretin-based therapies show an increase on the HOMA beta and fasting C-peptide levels, and also achieve a reduction of the HOMA insulin resistance and fasting glucose versus the placebo. DPP-4 inhibitors have a protective effect on the beta cell function. There is more and more emerging data on the same. Addition of vildagliptin to metformin improves glycemic control and beta cell function. The verified data showed the beta cell function improving with the early combination treatment with vildagliptin and metformin in patients with newly diagnosed type 2 diabetes. The verified trial suggests that an early combination with vildagliptin and metformin in patients with newly diagnosed type 2 significantly and consistently improves long-term glycemic durability. And that's important, not only significant, but consistent, and it continues to be durable as compared to just the standard metformin therapy. When started on metformin, unfortunately, Indian patients tend to fail earlier, even as compared to the global counterparts who responded for at least 3 years, but in the Indians did only for 1.5 years as compared to 5 years durability with the combination therapy. With that, I thank you again for inviting me for this session, and hand it back to the chairpersons for any question and answers or discussion.
Thank you, Manoj sir. It was really very pleasant to hear to your talk. And before we open up for the Q&A, with the permission of my co-chair, I would be the first person to ask the questions from my side. Well, DPP-4 inhibitors have really established themselves, and then they're still going strong, and they're going to stay in this coming decade as well. And you have presented very good data, whether it is Verify or whether it comes to sitagliptin. All these gliptins, as a class effect, they have done wonders in terms of preservation of the beta cells. There is another set of molecules which are, I think, probably, I would say that they would be the molecules for this coming decade. SGLT2 inhibitors. And what's your impression or take on this group of molecules with regards to the beta cell preservations, when they have already come as the second line drugs after metformin, as per the latest ADA guidelines and these things? Comments, please.
So, you want me to take that, Dr. Shrikant?
Yes, sir.
Okay,
yeah.
Thank you. Well, so yes, I think these two continue to be those wonder drugs in the last 2 decades that we've had, the DPP-4s followed by SGLT2 inhibitors. Now, clearly the strength of evidence towards the cardiorenal benefits are largely being seen by SGLT2 inhibitors. We have seen evidence for renal benefits even for DPP-4 inhibitors, but one may argue and see that the kind of renal endpoints that we have seen in the renal dedicated or CVOTs for SGLT2 inhibitors have not been matched by the DPP-4 inhibitors. As in terms of the cardiac benefits, the DPP-4 inhibitors at the most have been found to be non-inferior or safe, except for the issues that we saw with SAXA and hospitalization. But the SGLT2 inhibitors clearly showing the cardiac superiority. These two drugs, I don't think it would be fair to pitch them up against each other. Clearly, for us in managing our patients with diabetes, we need these drugs and many more in our armamentarium to get many of our patients to control and to prevent the complications in the long run. The fact that today most bodies clearly say that you should use SGLT2 inhibitors or GLP-1s right up there, post-metformin, or the ESC going to the extent and saying that forget even metformin and directly go for these drugs. is based on the strong evidence of their cardiorenal protection. Having said that, I think there is strength in each of these drugs. For example, in favor of DPP-4 inhibitors, I'm sure all of you would agree that these are drugs which have proven efficacy. And I think efficacy clearly, we cannot go by that 0.6, 0.7% reduction as shown, far more clearly evident in the Asian population that we respond much better to DPP-4 inhibitors. And what data I showed from the initial study, I'm sure all of us will have many examples from our clinics where your patients with high A1Cs have responded to 2.5 or 3 or 4% also at times. The important thing that goes in favor of DPP-4 inhibitors today is that they're extremely safe. And these are the kind of drugs where you without much consideration you can offer it to the elderly, you could offer it to somebody who doesn't have enough support system, somebody who may not follow up for a while. So are you going to be tracking their incidence of genitourinary infection or any issues with dehydration, postural hypotension, electrolyte imbalance, and so on? So clearly DPP-4 inhibitors, if you don't want a headache, you want somebody to respond, you will go with it. Yes, they do not have the benefit of SGLT2 inhibitors. You have a patient who has multiple risk factors, who has those comorbidities. I may want to place an SGLT2 inhibitor clearly much above. But with some caution there, that you need to be on the watch out with these patients for incidence of the side effects. Having said that, they've gone ahead and said today that irrespective of the HbA1c, you consider where patients have renal or heart failure issues, offer them SGLT2 inhibitors. But we still don't have data for patients with lower HbA1c. The data that you have for Verify, where in the population you've included patients at 6.5 to 7.5, some patients in the study actually lower than that. We do not have that data yet in the patients in that niche. Let's understand and appreciate that all the SGLT2 data that we have today is in sicker patients. Most of those trials, including the ones we look at, DAPA-CKD or Emperor reduced, all of these are patients in sicker patients. Sicker patients have definitely responded very well to SGLT2 inhibitors. Can we extrapolate those benefits in patients who are drug naive, who are beginning their journey? Are you and me absolutely confident that we can give that without side effect? Do we want to take the chance that patients get further dejected by the side effect and completely move out from our modern medicine and start getting into alternative medicine? I think these are some of the concerns in our mind. So SGLT2, great drugs, but I'm not yet jumping the bandwagon and preferring them right in the beginning. I think it's safer from the DPP-4 metformin segment there.
So I want to ask a question, if I might. May I, Dr. Srinivas?
Yes, Santosh. Yeah, please.
I'm going to play the devil's advocate over here. I'm going to give a case scenario to Dr. Ravi Kumar and Dr. Manoj Chawla. Here is a man who is a BMI of 29, has newly diagnosed diabetes with an HbA1c of 7.2. He says, I would rather do a keto diet to control my diabetes first. Okay. But Dr. Chawla says, no, it's better to start with DPP-4 inhibitors plus metformin directly. So, let's take it one after the other. A practical approach. I'm not wanting for a debate type of approach. Practical approach, Dr. Ravi first, and if possible, then Dr.
Dr. Santosh always plays devil's advocate, so it is nothing new. Anyways, this is what we are saying is a newly detected type 2 diabetes with a A1C of 7.5, you are saying, and he wants to start with a keto diet. You want to start with the keto diet. I would ask him, first you come and how far we can monitor this patient. That is much more important. Suppose a patient in a busy practice like us, where you see hundreds of patients, it is not at all possible to give the time to the required that is to manage such type of patients. Number one, if you have a team, if you have a good team who can follow this type of patients and whether you can monitor these patients properly, I think why not? We can give it. But what you are suggesting is how much calories we can give to this type of patient. Now the evidence, what you are saying is, these are all short-term evidence. What I presented is all short-term. In fact, it has been shown that only up to 6 months and some maximum up to 1 year. So beyond 1 year, what happens to this keto diet and whether it is going to any adverse effect in the long run, we never know now. Now we are not have any evidence to say that suppose say 5 years, 6 years, or 7 years, we don't know what is going to happen. So I will not play any devil's advocate. I will follow with the standard treatment at present. Till we have a long data, probably maybe around 5 years, 10 years data, with then I think probably I will consider going ahead with this.
So Manoj need not answer now.
Shouldn't I? If you want me to, I will add my 2 bit
No,
there.
I think you did a great job, Manoj. But about SGLT2, I think now that off patency and availability at 10 rupees, I think it's a great drug to give it to literally to every patient. And coming to your adverse event, the concerns what you had, definitely there are. But once the adverse events occurs, the patients will present back to us, especially the UTI or the mycotic infections. There is no doubt about that. And about electrolytes, elderly, there is a dedicated trials now, the Emprise trial, the average, the age group was 65 and above. So we have enough evidences, the safety about the SGLT2. Of course, DPP-4s definitely were the drugs, and they were the first ones to have, after about 2 decades of our routine treatment, that they were the first drugs to come into our rescue in our treatment. But now I think it's definitely taken a backseat after the SGLT2s and the GLP-1s. Of course, GLP-1s still injectables. SEMA, I think it's going to be launched in July, August in our country, the tablet form. That probably is a game changer, will be a competitor for SGLT2 for sure. But I think SGLT2, taking the advantage of the cost and the benefits which is shown across the studies, I think that should be the first choice after metformin in most of our patients, considering the cost benefit.
Santosh, if I can just add in, Dr. Srinivas, right?
Yeah,
so I'm not contending your thoughts on SGLTs. As I said, great drugs. I'm just going back to Santosh's hypothetical case. So Santosh, one, I'm not a fan of keto diet. And apologies, I know that at some point you were doing it and pretty successful at it yourself. The last time that I met you, I don't know where that was, you were doing it. But having said that, I myself don't continue to be a fan of these diets. And but at the same time, there's somebody who is at 7.2, younger, as you said, who believes that he or she can change and that they can bring about a change in the lifestyle and do not want to start drugs. I'm absolutely for it. And somebody who's driven, many of them would be able to do that and get down from 7.2 to 6.4 or 6.2. They're absolutely fine. The point remains that somebody who's not driven and yet does not want to start drugs and wants magic to happen, then I'm no PC Sarkar to do that. So clearly, when somebody is driven, we do give them time. However, if they don't respond, then that's the time that we start considering therapy. The point is, yes, in a lot of patients, we would still want to do traditional and start with metformin. But let's keep in mind that metformin, if you're not getting the desired response, forget what the data I showed, forget this. If you're not getting the response in the first 3 to 6 months, significant, do not go on increasing. Consider the second drug, be it an SGLT or be it a DPP-4.
Great. I think hit early is the key in our treatment, and that's what we should focus in our treatment. I think we are on time. I think 1 minute away from the time. So I think we should close it with the permission of our Dr. Srikanth sir.
Yes, sir. I think we had a great time.
Santosh and Hari.
Can I just add one thing for the conclusion? I think putting everything in perspective, what Dr. Ravi Kumar has said, that's a good low-calorie diet with a good exercise pattern, and with what Dr. Manoj Chawla says, that a good treatment either with a SGLT2 inhibitor or with a DPP-4 inhibitor to keep in HbA1c to below 6.5 should be our target. As he rightly said, I don't think we should reach a competition over here, because if and when, God forbid, if we develop diabetes, we will be taking both SGLT2 inhibitors or DPP-4 inhibitors at some stage of our illness, rather than saying that this is better than that, that is better than this. We should do anything that helps us, whether it's the diet, whether it's the exercise, to keep the HbA1c below 6.5, because all these modifications are non-hypoglycemic modifications. You're talking about metformin, you're talking about DPP-4, SGLT2 inhibitors, diet. So those are all, we should take the help of all the available treatments, including what Dr. Ravi Kumar says and what Dr. Manoj Chawla says and Dr. Srinivas Murthy rightly says. We should help in keep the HbA1c to less than 6.5 with whatever is available with us right now.
Thank you, Santosh.
Thank you, everyone.
Thank you, Santosh.
Best of it. Shanmugal sir, good evening.
Good morning. Thank you.
Thank you, Professor Srinivas Murthy and Dr. Srikanth for the excellent sharing, and Dr. Chawla and Dr. Ravi Kumar for the excellent talks. I'm sure some of the people would be interested in reversing straight away from now onwards and may not be with the diet, but we shall hope that somebody reverses with this. We will move on to the next session. For this session, I invite Dr. Shenmugvelu from Trichy. Can we have the CV slides of the chairpersons, please? and Dr. Shastri from Hyderabad as the chairpersons. Dr. Shastri is fast CP from Edinburgh. He is the consultant director at Mohan's Diabetic Center, Domalguda, senior physician and a very popular amongst the patients for managing his diabetes. And Dr. Shenmugvelu is from Tirchi. He is the specialist in internal medicine at Tirchi Diabetes Specialty Center and secretary of RSSDI, and a whole host of participation in the national and international clinical trials, and honored with plenty of awards from most of the organizations of diabetes. We welcome you to the chairing this session, sir. Over to chairpersons.
Thank you, Majors Magna, for giving the opportunity. Let me have the privilege of introducing the topic as well as the speaker. The first talk is on non-alcoholic fatty liver disease, NAFLD, by Dr. P. Jayaprakash, and from Cochin. He's from Government Medical College and trained in general medicine and prestigious Madras Medical College, Chennai, and a state topper. He then underwent endocrinology treatment in PGM Chandigarh. Is a consultant endocrinologist at Medical Trust Hospital, Cochin. So now he'll be talking on this non-alcoholic fatty liver disease in diabetes. You all know that the prevalence of NAFLD is very much high, and some percentage of people, they go on to progress to NASH, and another 10 to 15% may progress to cirrhosis of liver. And he'll be talking about the practical approaches, management, and diagnosis. Over to Dr. Jayaprakash.
Thank you, chairpersons. Thank you, Team Magna, for giving me the opportunity to interact with you. I hope my slides are visible and I'm audible.
Yes.
So I'll be talking on the subject of non-alcoholic fatty liver disease in diabetes, issues and practical management. So what is NAFLD? We have been hearing this term since our undergraduate days, and it's a simple definition. Even though the disease is complex, it's defined by the presence of more than 5% triglycerides in the liver cells, that is hepatic steatosis, either by imaging or by histology. So this is what happens. There is an excess of free fatty acids, whether it's from the diet, which is by the chylomicrons, or from the plasma-derived esterification of free fatty acids from the adipose tissue. And all of this is mainly loaded into the liver, and the fate of these free fatty acids depend on the metabolic condition of the person and the liver. So if it's an unfavorable condition, more of this is made into triglyceride, and this gets deposited into the liver, and then this causes the hepatic steatosis, and output of this can be kind of overthrown into the blood and excess of VLDL and the dyslipidemia and other factors. So the drivers of what these free fatty acids go into, whether it's a harmful pathway or to the harmless pathway, depends on the milieu. So it can be driven by the lipotoxicity, the mitochondrial damage, the oxidative stress, family history. All these things can drive the presence of fatty liver disease. And diabetes, even though we talk about the kidney disease, the heart disease, and the things we endocrinologists or diabetologists focus on this, but we should understand that 50% of patients with diabetes have some form of liver disease, and actually liver disease is the fourth leading cause of death in patients with diabetes. And liver disease can also lead to diabetes. Earlier there was an entity which was named with that, but now we don't count that. It's just because of the common factors which are associated with this. And mind you, this non-alcoholic fatty liver disease is not only associated with the metabolic syndrome, diabetes, and obesity and other things. It's also associated with cardiovascular disease, chronic kidney disease, PCOD, psoriasis, liver-related complications, malignancy, osteoporosis, sleep apnea. So all this umbrella of diseases, which we call as lifestyle diseases, is also associated and is common in patients with non-alcoholic fatty liver disease. Mortality is higher in these patients who have non-alcoholic fatty liver disease. And again, the major cause of mortality is cardiovascular disease. this is the prevalence of NAFLD from the worldwide data. If you can see over here, our Indian map, we are in the red. We have a prevalence of more than 30%. This is a publication in the Nature Reviews in around 3 years back. So the NAFLD prevalence, this is the general population, not in diabetes patients alone, it's more than 30%. And it's among the highest in the world in our country also. There is a study which is almost 7 years back, published from JAPI, by the name Sprint study from Dr. Sanjay Kalra's group, where they found that almost 1,000 patients of diabetes, more than 56% of them have non-alcoholic fatty liver disease, and it was more in females, 60% versus 54% in males. And it was more in northern states, 72% compared to 44% in western. So this again was shown in that worldwide study also, where we see that NAFLD prevalence is much higher compared to the worldwide data, and the prevalence is even higher in patients with diabetes. There's a data in 2019, again, mainly US data, which shows that more than 6 of diabetes patients and 9 of other severe people have NAFLD, and 1 in 4 people worldwide has fatty liver disease regardless of weight. So again, it's a lifestyle disease. As we have discussed, the pathogenesis is, there are various theories. The common causative factor is said to be insulin resistance. Again, the drivers are central obesity and the other conditions which are associated with that. So it's a common pool, and that's why patients with diabetes are also having a higher incidence of prevalence of fatty liver disease. It's actually a continuum from normal liver. You have this steatosis where, as we are seeing, the definition increases when the fat content increases by more than to 5 or more than 5%. It's called steatosis or non-alcoholic fatty liver. If there is a hepatocellular injury associated with that, an insult by form of an inflammation, which this is called as steatohepatitis or NASH, and then it can progress to cirrhosis and even HCC. Actually, now even data from India says that it's mostly the non-alcoholic fatty liver disease and NASH, which is actually more causative for hepatocellular carcinoma rather than alcohol-related liver disease. The spectrum by histology, the simple steatosis where only fat cells are seen, the steatohepatitis or NASH, where you have a considerable amount of inflammation and cell injury is there, then the stage of fibrosis where already these things have set in, and unfortunately we cannot do anything to reverse. So this is a natural history. Many patients fortunately do remain in that simple steatosis phase, but around 40 to 50% of them progress. Out of that, almost 8% of them progress rapidly to NASH with severe fibrosis, while mostly these patients progress in a slow pace to around 12 to 40% of them progress to NASH without severe fibrosis. And among this, again, half of them progress with the rapid progress to cirrhosis. So basically those patients who progress rapidly to hepatitis, steatohepatitis, they are at the highest risk of progressing to cirrhosis. Only 1% of simple steatosis straight away progress to the cirrhotic stage. So there are certain guidelines. I will mostly go by the American Association of Study of Liver Disease, the ASLD. That's the most evidence-based guideline that we have, and the recent guideline. ADA and the ESD also has some portions of their guideline dedicated to fatty liver disease. So the ASL is the Study of Liver Disease body. They again, out of these bodies, they are uniformly telling that we should suspect non-alcoholic fatty liver disease and NASH and determine the patient's risk for adverse fibrosis. Higher the amount of the comorbid risk factors, the more the chance of them developing to more severe stages of fatty liver disease and cirrhosis. So this is again the data from US, which looks into the prevalence of non-alcoholic fatty liver disease by more advanced MR imaging. The Indian study that used AST and ALT, we know the sensitivity is lesser for that. This is by advanced imaging, where they found that patients who are insulin naive, patients, more than 75% of them had prevalence of non-alcoholic fatty liver disease. Patients on insulin, 61%. So a very high rate of prevalence of non-alcoholic fatty liver disease in US population. It also, as I said, depending on the diagnostic approach, the prevalence rates varies. So if you only use plasma ALT, the pickup rate is only around 20%. The more advanced imaging techniques like elastography and MRS, you pick up more fatty liver disease. So it's also the diagnostic method that you use, which also determining the prevalence rate. The metabolic factors, again, one thing which you need to understand is that all these common things, whether it's hyperinsulinemia or diabetes or NAFLD, they lead to excess of cardiovascular disease. And that's why the mortality associated with non-alcoholic fatty liver disease versus steatohepatitis, both is at increased risk of mortality. If you see the green chart is other mortality, the orange one is cardiovascular related mortality. The blue one is liver related mortality. So when you go from normal to non-alcoholic fatty liver disease, the cardiovascular mortality increases. And when you go to steatohepatitis stage, it's actually the liver related mortality, then liver disease mortality which increases. The cardiovascular mortality is almost similar. So that means from the stage of normal liver to non-alcoholic fatty liver disease, there is almost double the rate of cardiovascular disease related mortality, which actually doesn't increase much further. So this is the same data which is shown in a different way. The liver related mortality kind of jumps up when you have a diagnosis of steatohepatitis, while the all-cause mortality starts increasing, mainly driven by the cardiovascular disease, even at the stage of non-alcoholic fatty liver disease. So that's where the question of statins come in. We know there was an initial, probably a decade before, there was some doubts regarding statins adversely affecting the transaminase level. It can adversely affect the non-alcoholic fatty liver disease. But that has now been conclusively proven. This data which shows that patients already on statin or added statin, their liver enzymes actually over a period of 3 years doesn't vary much. So the guidance is that patients should be given statins, even if they are NAFLD. It's actually for reducing the cardiovascular risk, not for resolving NASH. So it doesn't affect the natural history of fatty liver disease or its progression to NASH, but then we know how beneficial it is in terms of reducing cardiovascular risk. And the fact that patients with NAFLD has an increased cardiovascular risk makes it even more important that these patients should be given statins. So there is no doubt regarding the usage of statins in NAFLD or NASH or even in cirrhosis. Patients should be given statin, especially if they have diabetes. Going to the signs and symptoms of non-alcoholic fatty liver disease, it's very, they don't have any specific signs and symptoms, as you know. Some can have a vague right upper quadrant pain, hepatomegaly, deranged LFT, and it's mostly an incidental finding in ultrasound that we see. And there is data with respect to the varying presentation in Indian population. We have a generally milder presentation. They may not be as overweight or obese, just like the Western counterparts. Even just like diabetes, even normal BMI, NAFLD is also common in our patients. And obviously the insulin resistance is very common. There can be associated with serum and liver iron abnormalities. There can be an overshoot of that. So the diagnosis and evaluation, we know the usage of liver function test and the liver enzymes, which are the first indicators. Other liver function parameters need also be assessed, especially as the disease progresses. Alcoholic fatty liver disease should be excluded because the presentation can be similar. Imaging will do that, and liver biopsy will see how it is. So this is the biochemistry, even though these are not very watertight areas, but then we see the ALT to be increased in non-alcoholic fatty liver disease, while it's predominantly AST, which is increased in alcoholic liver disease, the ratio less than 1 and more than 1. GGT is more commonly elevated in alcoholic liver disease, and obviously patient can give a history of alcohol intake. Again, these are not very specific, but this would help. Imaging techniques, ultrasound is very easily used and very commonly used, and the sensitivity is almost 90% to 93% in diagnosis. But as the patient is more obese, the sensitivity falls to less than 50%. The usual CT and MRI has actually no advantage, but specialized non-invasive fibrosis imaging techniques which are available, especially the elastography, the fibroscan and other MR elastography, they are far more superior in picking up, and the sensitivity rate is much better, as we have seen. So this is a chart showing the non-invasive tests. These are mainly the gastroenterologist or hepatologist purview, but then as we see, the sensitivity and specificity increases with these fibroscan and MR elastography techniques. Liver biopsy is actually the gold standard. It only can pick up the steatohepatitis from simple steatosis, and it's indicated in certain situations where we think that it's rapidly progressing, and if you want to rule out other conditions. But in common simple fatty liver disease, it's actually not indicated. So there is an actually call to action chart. This is given by the American Association of Liver Disease for endocrinologists in terms of how to go about in patients with pre-diabetes and diabetes. When you find an elevated liver enzyme, you have certain parameters. The duration of diabetes, like you have this chart of more than 10 years of duration of diabetes, with an A1C of more than 8.5, evidence of steatosis, triglyceride of more than 250. These are the patients who need actually more advanced assessment of fibrosis to determine whether they are in steatohepatitis or not, because that's a stage where we can arrest the progression by certain interventional techniques, or you can observe them. So depending on the fibrosis, we need to intensify the measures, we need to decide on liver biopsy, and go about managing these patients. This chart, the call to action for diabetologists or endocrinologists, is very useful actually. Coming to the management consists of, just like diabetes, the lifestyle modification, the drugs targeting the fatty liver disease, and also the managing of the cardiovascular disease risk. So it is similar to the management of diabetes. We need to assess the lifestyle part, we need to have a pharmacotherapy, and also assess the largest risk, which is the cardiovascular risk. So the lifestyle modification, again, similar to what we advise our patients with diabetes: calorie restriction, weight loss, exercise, and also alcohol has got an added insult. So no heavy alcohol, rather it's advisable to stop alcohol consumption. So this is the effect of lifestyle interventions in terms of the resolution and the regression of already established fibrosis. So if you see, a weight loss of around 5% helps in the resolution of around 10% of NASH. 7% of weight loss, if you can achieve, then it's around 26 to 64%. And if you can achieve more than 10% of weight loss, the resolution of NASH is almost 90%. So this is very important. But if you see the row at the bottom, the percentage of patients achieving this weight loss, if you see this 10% of weight loss, only 10% of weight loss is achieved by only 10% of patients. So that's what we see in our practice also. So even though it looks very fruitful, but the amount of weight loss, the 10% of weight loss is achieved by hardly 10% of patients. So that's why the results are also kind of lesser when you go about, when you modify the lifestyle alone. So reducing the calorie intake is effective, especially the Mediterranean diet, which is found in this NEGM study, that it has found to improve hepatic steatosis. The liver fat mass is also favorably reduced. And it's not only the liver, fatty liver disease part, all the other associated diseases like diabetes, the cardiovascular disease, and liver disease death also can be attenuated. So that's the importance of lifestyle modification. You're not addressing the liver part alone. We are addressing the diabetes part and the cardiovascular risk part of these patients by modifying the lifestyle. So this is the practice guideline, which I'll be mostly referring to in the subsequent slides with respect to the pharmacotherapy. So the non-pharmacological approach, again, the ASLD guidelines is very clear regarding weight loss and exercise. There is also a mention of bariatric surgery. We know the effect of that in terms of weight loss, and actually they tell that it's premature to consider bariatric surgery as an established option just to treat NASH. So if the patient is otherwise indicated for bariatric surgery with respect to his weight and other conditions, you can go ahead. But just for the treatment of fatty liver disease or NASH, it's not an indication. So this is the percentage. Again, if you can achieve more than 10% of weight loss, the fibrosis regression and NASH resolution is to the tune of 45 to 90% of patients. The medications for weight loss, we have lorcaserin is not there. There's orlistat and other drugs which are available in the West. If you see over here, they achieve weight loss, but the improvement, the last part, the improvement in NAFLD is actually not studied, except some drugs like liraglutide, which we'll deal with in the subsequent slides. Study with orlistat, again, orlistat has shown that it improves weight, especially the Western studies, but no improvement in liver fibrosis score. So for fatty liver disease, orlistat is not an option. Bariatric surgery, it shows improvement. This is a meta-analysis of 32 studies. It showed that the outcome, there is an improvement in outcome in more than 50% of patients. The patient selection has been right. So this is the remission of NASH and improvement in fibrosis, almost 85% of remission with steatohepatitis and 43% improvement in fibrosis score with after bariatric surgery. So this is summary of weight loss in NAFLD. Yes, all patients need that diet, exercise, and lifestyle. And adjunct pharmacological approach in overweight individual, BMI more than 27%, with the aim of reducing weight around 5 to 10% if it's achievable, is beneficial. Now let's look at the specific liver-directed therapies. So there is actually an uncertainty about the best targets, whether it's the metabolic target or inflammatory target or fibrotic target and apoptotic. So that's why there are various drugs which try to target these various pathways, and not all of them have been found to be beneficial. One of the important drugs as we physicians treating diabetes is pioglitazone, which has undoubtedly proven to be effective. Pioglitazone is approved for treatment of fatty liver disease and NASH in patients with diabetes, this is a study, the PIVAN study, which has shown that this is a comparison between vitamin E and pioglitazone. The green one is pioglitazone, the blue one is vitamin E, the orange is placebo. So across all spectrums, whether it's steatosis or fibrosis or the ballooning stage, pioglitazone is effective. The p-value is significant, and in most stages, pioglitazone is more effective than vitamin E in patients with fatty liver disease. Vitamin E is also shown to be improved, but again, these are the data is more in patients without diabetes, the improvement stages. So that's why these drugs are having its own side effects. Vitamin E, actually more than 800 international units per day is found to have a possibly increased mortality risk, increased risk of hemorrhagic stroke, and increased prostate carcinoma risk. So vitamin E is not actually recommended for patients with diabetes, while pioglitazone, even though we know the risk factors, the side effect profile, edema, osteoporosis, and bladder cancer risk, it is actually indicated in histologically confirmed NASH after consideration of risk-benefit ratio. That's what the guideline says. Coming to our other drugs, metformin is actually not indicated, not recommended for treating NASH in adult patients. So metformin does not improve NASH, but for diabetes, we can use it. It doesn't adversely affect, but it's not a drug which is used to decrease fatty liver disease. The emerging drugs, SGLT2 inhibitors and GLP-1 receptor agonists. This is a very recent, just 2 weeks back, meta-analysis published, where they have looked into all the SGLT2 inhibitors, DAPA, EMPA, and CANA, and have shown that all of them decrease the fatty liver score across these meta-analyses. This is the empagliflozin study, the E-lift, which has found that empagliflozin has a significant benefit, 10 milligram, and another study with CANA also have shown that it lowers the NAFLD scores. So all these DAPA, CANA, EMPA, and even empagliflozin have shown studies which have shown that it improves the liver fat content. The GLP-1 receptor agonist, the lean study with liraglutide have shown that it shows a histological improvement. So the histologic biopsy-proven improvement and also the imaging improvement is shown with liraglutide. Again, this same issue had a meta-analysis of GLP-1 receptor agonists, and if you see all of them, liraglutide, exenatide, and dulaglutide have data which shows that it can have improvement in fatty liver disease. November 2020, NEJM has a trial of injectable semaglutide in NASH. Again, it was found that the ALT and AST and imaging parameters improves with semaglutide. So we have data which shows more robust data than SGLT2 inhibitors, which have shown that it improves fat content, and biopsy-proven data with liraglutide and semaglutide, which shows that it can have an improvement in terms of steatohepatitis also. So that's why, as of now, the guidelines recommend pioglitazone. This chart mentions about other oral antidiabetic agents also. Metformin, sitagliptin, results have been negative. Liraglutide, pioglitazone, EMPA, CANA, and semaglutide have shown to be improvement in terms of fatty liver disease. So the guideline shows that pioglitazone is useful, but vitamin E with biopsy-proven NASH may be used in patients without type 2 diabetes. Type 2 diabetes, the side effect profile is more with vitamin D. So here we have pioglitazone only as the approved agent. Now let's look at the other agents which we commonly find. One of the agents from India is seraglitazar. This is a publication of seraglitazar in Nature Scientific Reports, which have come late last year, which they have shown that it improves. We know the effect, the alpha and gamma dual agonist, which has a favorable effect in the liver and also the metabolic profile of the individual. So this study has shown that it improves ALT, AST, and the liver fibrosis parameters. So that's why actually seraglitazar has got approval from the Drug Controller General of India for usage of non-alcoholic fatty liver disease in India. 4 milligram of seraglitazar. This is the document on December 30th of 2020. One of the most common agents that we were using are some of we see still the prescription of ursodeoxycholic acid. Actually, the guidelines do not recommend it for the treatment of NAFLD or NASH because it has not shown to be of any benefit. Omega-3 fatty acids also, they tell that it should not be used as specific treatment for NAFLD or NASH, but may be considered to treat hypertriglyceridemia in patients with NAFLD. So if they have hypertriglyceridemia, omega-3 fatty acids can be used, but it has not shown any improvement. UDCA has not shown any improvement in non-alcoholic fatty liver disease or NASH. One of the other agents which have been come into the market used recently is the obeticholic acid, which is a farnesolic acid X receptor agonist. It has shown benefit. This is a Regenerate study, which is again shown a US study, which have shown that this obeticholic acid, 25 milligram, had resolution of NASH in 25% of patients. These patients were having diabetes predominantly. Compared to 11%. So this agent, the obeticholic acid, is found to be effective, and probably the next guideline it would get approved. There are various investigational agents which are being tried into. As I said, the metabolic pathway, the inflammatory pathway, all these pathways have been evaluated. Many of these agents have fallen in their way in terms of they're not showing the promise. They'll be showing the promise, but end results have not been beneficial. So many agents, if you can see the names, complicated names all over here. So research is going on in terms of addressing this progression of the fatty liver disease in terms of this. What about the follow-up guidelines? There is a recent publication, 2 years back publication in IJM, where the follow-up of patients with NAFLD in diabetes have been suggested. So patients without worsening of metabolic risk factors, they need follow-up of evaluation for NAFLD once in 2 to 3 years. When you have NASH or those with fibrosis annually and NASH with cirrhosis once in 6 months, high risk of progression, they need liver biopsy after 5 years of follow-up. With fibrosis and hypertension, close monitoring because of higher risk of progression, and cirrhosis, obviously, under gastroenterology care. So summarizing, we have seen that obesity and diabetes highlight patients at high risk of NASH and cirrhosis and CVD. We need to understand that it's a continuum of these risk factors, which obviously leads to CVD most of these patients. Evaluation of NASH in patients with diabetes requires a higher degree of suspicion. We need to find these patients early on, and aggressive lifestyle modification and correction of metabolic parameters as far as possible. Pioglitazone is, as of now, the only approved drug. In India, we have saroglitazone also as approved. And GLP-1 receptor agonists and SGLT2 inhibitors show promising results, and probably in subsequent years, we'll have guidelines also updating the recommendation of usage of these drugs in patients with diabetes, which would help us. Thank you.
Yeah, Dr. Shanmugsundaram, Shanmugavedu.
Yes.
Yeah. Over to you.
Yes, thank you, Dr. Sastry, for inviting me to say a few words about non-alcoholic fatty liver disease. Shall we take the question and discussion at the end of both the speakers' talk, or can we take right now, sir?
At the end of the session, I think.
Okay, right. Dr. Jayaprakash, congratulations. You have gone through extensively. It was a really insightful and lucid presentation on non-alcoholic fatty liver disease. And so we'll discuss, and then please stay with us. Next, let us move on to the psychosocial aspects of diabetes management. Also, the speaker, Dr. Vimal, will also touch upon the sleep in diabetes also. Dr. Vimal, Colonel Vimal, is a senior consultant endocrinologist, Omim Base Hospital, Eastern Command, Guwahati. He has more than 45 publications to his name. And with reference to the topic introduction, several hormones can influence the sleep pattern, starting from melatonin, cortisol, thyroid hormones, estrogen, progesterone, testosterone, and imbalance in these hormones can influence the sleep pattern. So with this introductory remarks, may I call upon Dr. Vimal to take all of us through his presentation on the topics given. Before that, I would like to thank Dr. Shanmugsundaram for inviting me to chair this session. Yes, over to Dr. Vimal.
Just a small housekeeping announcement. Dr. Vimal, please switch on your video. And this is the last session of this hall. And we have an interesting debate coming up in the next, from 1:30 onwards in the Fort St. George Hall. So after this talk, I request all the delegates to move to the next hall. Over to Dr. Vimal.
Am I seen, sir? Am my slides being seen?
Yes.
Yeah.
Yes.
Am I audible, sir?
Yeah.
Yes, sir. Yes, sir.
Yeah,
Fine.
thank you,
You're
sir.
audible and visible.
Yeah, thank you, sir. Thanks for the kind introduction. Actually, the topic got changed a little bit. Today, I will be speaking about psychological aspects of diabetes management, to see the psychological part of management of diabetes. As per the ADA guidelines, the recommendations for adults with diabetes, HbA1c control should be less than 7%. Preprandial plasma glucose 90 to 130, and postprandial less than 180 milligram per deciliter. This is all well known to us. However, if we see in our practice, there are just about 50% or maybe 60% of the patients who achieve this control of 7%, and even fewer with less than 6.5%. So we have a scope for further improvement. What are the challenges we face in management of diabetes? There are problems with glucose lowering therapies, including hypoglycemia, weight gain, frequent dose adjustments, and cost of therapy. then patients are more comfortable, I should say, or they are more better placed with treatment with alternative medications. Then they go on to bargaining with doctors, doctor shopping. They are not happy because being a chronic disease, all these things happen. Problems with associated therapies, problem with other comorbidities like cardiovascular, renal, other problems that they have. Patients' misconception about the disease and about the therapeutic modalities that we have. And in some cases, doctors' inertia also, especially in cases of insulin. Psychological issues like denial, depression, guilt, anger, anxiety, poor compliance. So this will be the part that I will be touching upon in today's presentation. And the greatest challenge out of these, what we face in as doctors in management of diabetes include problems with glucose lowering therapy, time constraint that we have, as some speakers earlier also told, that there's a very busy OPD and it's very difficult to see and devote adequate time to each patient. Patients wanting second opinions from other doctors, and very importantly, denial, anger, carelessness, frustration, and depression from the patient's side. So inability to grasp the disease and to accept what has happened. What disease has happened. So when as a doctor do we feel most perturbed by patient's psychological reaction? Patients give a psychological reaction. When do we find that the patient is most perturbed? At the various stages of the disease include at the onset of diabetes, when the diagnosis of diabetes is made in this patient. At the time when oral anti-diabetic medication is switched, which was working for years, it has suddenly failed. Patient was taking glimepiride and metformin, suddenly the HbA1c has started going up. So now the time for starting initiation of insulin has come. Patient definitely feels bad, and there is some sort of a with the patient. And at the time when we inform the patient that the complications of diabetes are now setting in, that is again the time when the patients are more prone to psychological reactions. So at the time of onset of diabetes, what are the different reactions that we see? Like, actually, doc, yesterday I had some sweets, so this sugars have come high. I would like to check them again. Maybe I should take a second opinion and find out there is a good doctor in my neighborhood or somebody who has treated my aunt and she says is very good. So should I take a second opinion? Oh, I've got diabetes. Will I die soon? The lab must be wrong. I cannot have diabetes. I've been exercising regularly. I take my diet properly. So I should not be having diabetes. And my parents left me with no money, but both of them had diabetes, so I also received diabetes. So these are various reactions that we get from the patients. So what is the implication of impact of chronic illness in this individual? Initial impact, as we just discussed, is either shock or of denial, loss and grief, anxiety and depression. And that is natural also. Somebody who is diagnosed with a chronic illness, these things would come. But if these reactions last too long, they can have a negative effect on the illness itself. The individual has to learn to adjust to symptoms of disease, stress of treatment. There is a feeling of vulnerability among the patients, loss of control over one's own life, threat to self-esteem. He feels, outdated from the society. Financial concerns are there, and changes in the family structure. Now everybody around has to adjust to the disease. So there are a lot of stresses in the patients. Similarly, the family of the patient or the immediate society also has to adjust. They have to adjust to increase stress, changes in the nature of a relationship. Now the diet pattern has to change. The timing of disease, the drugs have to be adhered to. All those issues start coming up. Changes in the family structure and the role. Now who has to take care of the individual? How do they confront him, or how do they adjust the medication, etc.? Loss of income. Maybe there is some issues with the job, especially if the patient is getting insulin. Like this happens in the services also. Patients on insulin, they don't get that much of job opportunity as otherwise they would get. And different issues for different relationships. Adult children of ill parents, they have to adjust. Spouse of ill person, they have to adjust. Parents of ill children, they have to change their lifestyle accordingly. So depression, is it the chicken or the egg? What does the data say? The data says that adults with depression have 37% increased risk of developing type 2 diabetes. And the pooled relative risk is 1.26, that is 26% higher, or using a fixed model or 1.3% using a random effect model. So patients having depression is a risk factor for onset of diabetes. The odds ratio are of 2. That is, if no diabetes, the chances are around 11.4% as per this study. And if diabetes is there, it becomes double, around 21%. Poor recognition of emotional problems by diabetes professional. Diabetes, the depression and the distress that the patient undergoes, it's usually missed by the physician and nurses in about 30 to 70% of cases. So almost 50% of patients, we are not aware that the patient is undergoing some psychological stresses. And severity of symptoms and cognitive symptoms are underestimated. And what are the cognitive symptoms? They include feeling of worthlessness, excessive or inappropriate guilt every day. And the poor fellow doesn't have anybody to talk to these also. And as a healthcare professional, we also fail to recognize these. Indecisiveness or diminished ability to think and to concentrate. And markedly diminished interest or pleasure in most of the activities throughout the day. So such patients, monitoring is advised. Consequences of untreated depression in diabetes. Quality of life gets lowered. Hyperglycemia and diabetes related complications, they increase. They require higher hospitalization. Mortality is definitely more in such patients. Cost of therapy increases. It is almost 86% higher than if the patient has only diabetes. And more days in bed, loss of productivity in these patients. So let's have a look at the cardiac risk factors in patients with diabetes mellitus and major depression. If the patient has no depression, the risk factor is about 40%. But if the patient has major depression, the risk factor goes about 65%. So there is a substantial increase in risk factors, which include more than 3 risk factors. That is smoking, body mass index of more than 30, and HbA1c of more than 88%, and sedentary lifestyle. So out of these, any 3, the percentage is definitely higher in people who have major depression as compared to no depression. Depression severity affects the cardiovascular risk factors. That is individual risk factors. Now we see smoking. If the patient has minor smoking, it is from 7%, it increases to 10.4%. And if you have major depression, then the smoking risk increases about more than 2-fold high. Similarly, for obesity, it is higher in patients who have minor or major depression. And other diabetes symptoms like cold hands and feet, numbness, pain in the hands and feet, polyuria, excessive hunger, abnormal thirst, shakiness, blurred vision, faint feeling, and daytime sleepiness, they are all higher, and the odds ratio are very significant for all these symptoms if the patient has associated major depression along with diabetes. The complications also, as the study shows, there is a significantly increase, though it's a small to moderate effect is there on the complications. And depression also reduces adherence to the medicine in patients with diabetes. So if we see the normal adherence in non-adherence in patients with non-depressed individual is about 19%. For oral hypoglycemics, it becomes about 25%. Similarly, lipid lowering medicines, they also increase. ACE inhibitors, they also increase. So across the spectrum, the non-adherence increases in depressed patients. What are the practical problems? They arise from depression, diabetes comorbidity. Now I'm discussing from this point of view of a psychologist or a psychiatrist, not from a point of view of an endocrinologist. So the attempt to regulate emotion with food or substance, that is the problem. Now the patient is trying to compensate with eating more food or taking some substances. So clinician is not able to understand the underlying depressive symptoms and whatever the emotional pain that he is undergoing, and may become judgmental because of the stigma attached to diabetes. Stresses that interfere with self-management strategies and worsen diabetes status may also precipitate or exacerbate depression. Again, patients and clinicians may attribute poor diabetes outcome to decreased self-management because of a busy lifestyle, etc., but do not attribute it to the concurrent depression that the patient may be having. Depression may reduce the ability of affected individual to trust others or to be satisfied with the health care. And depression is commonly associated with changes in healthcare seeking patterns and follow-up through appointments. This is the problem, the psychological problem that the patient undergoes, and the patient may be reluctant to make appointments, show up for appointments, seek support for healthcare because he's already depressed, but we may think that the patient is non-compliant with medicines. So what do we feel is the patient's prime psychological problems? We feel that the patient is more concerned about the number of pills, the cost of treatment, loss of self-esteem, position in the society goes down. Once he's labeled as a diabetic, he feels that he's become inferior to people other than who are non-diabetic, and self-esteem goes down. His independence to eat whenever he feels or do whatever he wanted to do, that goes. The now lifestyle is more restricted. So impact on depression recognition on treatment and diabetes. So if we as a clinician are able to recognize this depression, then what happens? Systemic treatment of depression in diabetes tends to better outcomes than care as usual. More patients receive adequate treatment, they undergo good psychotherapy sessions or antidepressants, and they have greater reduction in disease severity. The outcomes of depression and overall patient perception and function, they improve. Mortality reduces, especially in older patients with diabetes. The 5-year survival is almost double. Hazard ratio is about 0.49. So it has a direct impact on the mortality of patients. It is more cost effective with outpatient cost equivalent to care as usual, and reduced overall healthcare cost in over a period of 5 years. So it's very important to recognize depression and to treat it. The data comes from Pathways randomized controlled trial and impact trial also, that I'll be alluding to later. Here 9 primary care clinicians in Washington state were chosen, and the participants were assigned to pathway nurse collaborative care intervention versus usual care, the numbers being about 165 in both the arms. Usual care was primary care or referral to specialty mental health care as available, and Pathways care used collaborative stepped up care disease management program for depression in primary care, but not to directly improve diabetes education or care. The treatment was only for depression, the psychotherapy. Patients were offered choices of antidepressant medication or problem solving therapy. So they were given a choice whether to take medicine or to go with improved lifestyle, improved psychotherapy care. They were given one hour trial initially, followed by 30 minutes appointment twice a month, and a telephone care in person for 12 weeks, either telephonically or in person. And collaborative care treatment was delivered by the nurse. It was not given by the doctors. At 10 to 12 weeks, if the patient achieved more than 50% improvement, nurses began continuation phase with mortality, scheduled telephone contact. And if it was less than 50%, they were switched over to other treatments. And the data shows that with intervention, the mean SCL90 depression score that came down significantly in intervention arm as compared to the usual care. However, since they were not giving any targeted therapy for diabetes reduction, it was targeted for depression reduction. There was no changes in, not significant difference between the HbA1c care, though HbA1c improved slightly in both the arms. And this shows over 2 years the total hospitalization care. This is data from other study that was also similar. That shows that over 2 years the data from Pathways as well as from the impact, the other study, which shows overall total healthcare over 2 years that comes down as compared to the usual therapy. So there is a saving to the tune of about $1,000 in each of the study in over 2 years. Efficacy trial of medication for depression on treatment of diabetes. So if we search through literature, we will find all sorts of literature is available, and same thing with these trials also. They have shown mixed pattern. Some trials have shown there is improvement in depression, but not in glycemic control with nortriptyline or fluoxetine or other drugs, while other trials have shown improvement in depression as well as glycemic control in the treatment group as compared to the control group. So the data are they are mixed in psychotherapy for depression diabetes. So how do we take care of depression care in patients with diabetes? First step is to screen, and we should screen for depression with patient health questionnaire, that is PHQ-9. Helplessness, giving up, or sense of being overwhelmed about disease, self-management, that should be asked for. It also looks for comorbid panic attacks, post-traumatic stress disorder, inability to differentiate anxiety symptoms from diabetes symptoms like hypoglycemia, that can be common to both. Associating eating concerns, emotional eating in response to sadness, loneliness, anger, that is specifically looked into, about binge eating and purging also inquired about, and nighttime eating. Step 2 is improved self-management. Then we explore about the loss of control of diabetes self-management, explore about understanding of bidirectional link between the stress and suboptimal disease self-management and outcomes, define depression and how it overlaps and with distinct from other stresses of life, review symptoms of depression and how these symptoms overlap with and mimic with diabetes symptoms, discuss depression related medication, and break down tasks in self-management of diabetes, depression, or other illnesses, and help the patient to prioritize order of importance of specific tasks. And step 3 is to provide adequate support to these patients with an adjunctive psychotherapy for emotional eating, breaking down problems and improving treatment adherence with different modalities like cognitive behavioral therapy, problem-solving therapy, and motivational interviewing. So adherence can be improved in this patient by giving them information, by giving them motivation and behavioral skill, which results in a desired health behavior, and that ultimately may lead to improved glycemic control and improved diabetes endpoints. So some anecdotal situations: a 56-year-old lady, we see a breast post mastectomy, chemotherapy, and radiotherapy, was admitted for IV steroids for iatrogenic neuropathy. The problem was erratic glucose control. As you can see, the glucose levels are going very wonky in this patient. So when we spoke to the patient, it was found that she was depressed about her cancer, about her diabetes and hypertension as comorbidities. She was depressed about the side effects of the drugs and about the longevity of life and the quality of life. She was very dejected about the diet that we were giving, salt restricted diet as well as low glycemic index diet. Frequently she skips food, and insulin dosage also are skipped. She takes sometimes when she eats food, otherwise she avoids it. So just a small prescription change in dosage of insulin and a talk with the individual explaining her about the disease, the values destabilized. Other anecdotal situations that we came across while discussing with other colleagues is a patient was called for management of hyperglycemia, found that patient was repeatedly bothered about the bathroom door not closing. They got it repaired and the blood glucose controls improved. So things can be very trivial or very unrelated, but the patient it may be there in the subconscious of his mind, and if you take care of that, speak to the patient, things will improve. Somebody's surgery gets cancelled, they undergo stress. So we need to talk to the patient and try to find out if there are associated psychological aspects to the disease. Now coming to the second part, that is anxiety and diabetes. Anxiety disease disorders are more prevalent in diabetes than in community at large. Their disorders can be general anxiety disorder known as GAD, GAD, and panic disorders. They are more episodic in nature than major depressive disorders. Depressive disorders remain throughout, but anxiety, anxiety can be episodic. There is no clear association observed with HbA1c level, but they may lead to fluctuations in diabetes care in the day-to-day practice. And diabetes specific anxieties could be there, like fear of injection or self-testing due to blood injury illness phobia or fear of hypoglycemia. Let's see them one by one. Blood injury illness phobia. That patient is absolutely mortified of the injections or the site of an injection needle. So there's intense fear of injection or self-treating, self-testing. And lifetime prevalence of insulin requiring patient, this is about 3.5 percentage point, and associated with less frequent blood glucose testing and higher rates of diabetes related complications. So they just keep on postponing their self-monitoring to a later date. And not always a classical fainting, but the patient feels uncomfortable. Comorbid depression and anxiety is common in these groups, in this group. So intense anxiety to medicine, what are the common situation? What do the patient say? Doctor, can we avoid these medications? Can we reduce dosage? I am on 1000 milligrams of metformin. Can I take 500 instead? Stopping medicines because the patient feels weak after a few doses. And funnily also, this is very common with metformin, seeing the size and the milligrams on the tablet. Self-titration of dosage. They say, I have eaten less today, so I'll take this much, and I've eaten more. And they do it for all the medicines, for insulin, for sulfonylureas, for other medicines also. So anxiety barrier to insulinization. And anxiety can be on both sides. Can be patient side can be from the physician side also. So what are the physician's barriers? Physician's barriers are lack of time to tackle patient's anxiety and questions. You are very busy in the OPD, so you are not able to take care of the patient. And the patient is, the physician is bothered or is fearful of hypoglycemia that the patient might have. Worried about the patient may drop out from our follow-up because of some other alternative may be suggested by other individuals. Need for increased vigilance on the patient by email, phones, SMS, WhatsApp messages, because the patient is now taking insulin and needs to be under stricter control. And from the patient side, fear of needles is the biggest fear. Insulin is seen as a last stage medicine. So according to them, now the disease is much advanced. Cultural and social taboos associated with insulin and fear of hypoglycemia. Doctor worries about fear of injection. We don't inject ourselves, the nurse does. So doctor has to learn how to give injections first. Sometimes we use it as a threat. If you don't start exercises, I'll have to put you on insulin. Worried about the cost. We see that the insulins are very expensive, but we are not aware about the cost of the newer drugs that we have seen from the previous discussions. And we say that the insulin, whatever we are giving, it is not mimicking the normal physiology. It enters the peripheral circulation and not the portal circulation. Hypoglycemia versus complication. What is more desirable? So these are all the things that play into the mind of the doctors. And what are the patient's worries? Fear of injections, last stage medication, addiction. If I start taking insulin, I'll get used to it. I'll never be able to get off it. Social stigma and hypoglycemia versus complications again. Rigid lifestyle, because you have to eat immediately after you take insulin and you have to eat at a fixed time. So putting, late night, all those things have gone out. And cost of therapy definitely increases, so patient is worried about that also. Again, those things amplified. The patient says, I did this to myself, or my uncle went on insulin right before he lost his legs. So this is perceived as a severe disease, treatment for severe disease. So they realize that now the patient has reached the end stage in the diabetes, and it is a personal failure of some patients take it as a personal failure of themselves. Taking insulin is too complicated. You have to take it out of the refrigerator, you have to store them well, you have to carry them well, you have to inject them nicely. So all these things are very complicated. That's what is perceived. So once I start insulin, I'll never be able to stop it. So you have to start with as a temporary experiment. You say that let's try it for 1 month, we can stop it afterwards, and if you feel comfortable, then we'll progress with it. Also, starting with basal alone may be effective. Also, take any chance that the patient comes to us, sometimes getting admitted for other unrelated illness, that time expose the patient to insulin. I can't give myself injection, they'll hurt too much. That is the injection related anxiety that the patient may be having. So talking and speaking with the patient, discussing this all, the answer is education, education, and education. Sit down with the patient, speak to them, educate them about the disease and the treatment. Coming to fear of hypoglycemia, it is a diabetes specific fear. There is intense worrying about low blood sugars. It is continuous from mild to extreme. Some patient may be extremely phobic about getting hypoglycemia. They may have seen some adverse reaction to somebody else or some related patient. Higher risk in case of hypoglycemia unawareness. Patients who have hypoglycemia unawareness, the chances of going into neuroglycopenia are very high. Combined other comorbid anxieties and psychiatric disorders may be present. Avoidance behavior, active and passive, with subsequent poor diabetes control. So they tend to avoid taking medication because of the fear of hypoglycemia. And this is also present in parents as well as spouses of patients. And why does hypoglycemia cause anxiety? The symptoms are very unpleasant. It may be disruptive at times. The loss of control of patient over the self. It may cause accidents, especially if somebody is driving or standing near a machinery or at a height. A patient may harm others. There are cases where it can lead to brain damage, especially if the hypoglycemia is prolonged. The patient is alone in the room, like a type 1 diabetic child, staying in a hostel. and suddenly goes into hypoglycemia unattended. So this can relate to brain damage, even death. Social embarrassment. Once the patient develops hypoglycemia, they become, they are not in control of themselves. So negative relationship on effect on relationship, they may be burden to others, and similarly work performance goes down. Career progression also reduces. So risk factors and assessment, how do we do? We assess about impaired hypoglycemia awareness, any prior episode of severe hypoglycemia, high rate of anxiety, neuroticism, phobia, or having witnessed one or more episodes of hypoglycemia in other patients, partners, or child who has thrown a seizure, etc. These are the risk factors for hypoglycemia risk. And assessment is by observation, by seeing the HbA1c level. If after one hypoglycemia or more hypoglycemia, the HbA1c level starts rising, that means the adherence to medicine is going down. Reports from patient, we can directly ask them, and questionnaire like problem solving areas in diabetes scale and hypoglycemia fear survey. These questionnaire may be helpful in assessment of the hypoglycemia risk. Now coming to other disorders, they are eating disorders. About 10% of adolescent females with type 1 diabetes meet the DSM criteria for eating disorders compared to 4% in their age-matched peers without diabetes. And eating disorders are associated with poor metabolic control, earlier onset, and rapid progression of microvascular complications. And it should be suspected in those adolescent and young adults who are unable to achieve or maintain metabolic targets, especially when insulin omission is suspected. And important to identify individuals with eating disorders because different management strategies are required to optimize metabolic control and prevent microvascular complications, because they will not be taking the diet properly, and then they will not be taking the treatment properly. Coming to sleep and diabetes. Sleep
Dr. Vimal, can you wrap up, please?
Yes, sir. Yes, I'll just finish. Sleeping of less than 6 hours and even more than 9 hours is also associated with increased risk. So I'll go on to just a last couple of slides.
Please,
so if I ask the audience, when do we look for psychologist help in patients with diabetes? Among these, I'll find the upper two are more common. We generally do not look for it. So we should be looking actively for in patient with diabetes having any psychological disorders, and if it is not, then we should be screening for their social support, which is practical and emotional. And so we have to develop a positive focus and do not rely on any mental escape or avoidance behavior as these patients develop. And we should be the patient should be engaged in less self-blame, helplessness, anger or expression of emotions. Should not be blaming others. So to summarize, the psychological aspects of diabetes, they need to be understood. They're definitely there, and addressing each of these aspects will help us in achieving better glycemic control and may lower the complication and have better quality of life. Thank you so much, sir.
Thank you, Dr. Vimal. That is a wonderful and elaborate talk on psychosocial aspects of diabetes. And on a positive note, like those people who are living up to 100 years with diabetes, they have taken diabetes as a positive note, and they discipline their lifestyle and their food habits and other things, and they empowered themselves to be thing. That is one positive aspect as far as the diabetes is concerned. It is a small percentage of people. We publish that, and majority like type 1 diabetes and marriage is an issue. Maybe your comment on that, and that forum is open for discussion on psychosocial aspects of diabetes and NAFLD, Dr. Jay Prakash.
Correctly, sir. If there are very few patients who are able to adjust with the disease. If they do so, they tend to adhere very nicely with the medication, and they tend to have a better outcome as compared to those who are not able to adhere to, who take it as a personal failure. In fact, one of my patients, he is a retired colonel from the army. He was a gunner. He used to fire missiles. So he developed diabetes, and he took it as his personal failure. And at that time, he was commanding a battalion. He was a commanding officer of a unit, and he took it as his failure. And whatever I did for cajoling him, putting the idea of positivity in his mind, but he left the services. he just resigned. He took a premature retirement from the services. Though after that, after 1 or 2 years of constantly being in touch with him and all, then he's taken it very nicely. He's doing very well outside also. But these are the things, even the best of the people, the toughest of the lot, how they behave, it's very difficult to preempt. And coming to your second point about the marriage and type 1 diabetes, especially with the girl child, it's a real shame that they have to hide it, and it becomes really socially embarrassing for the child as well as the family because of the associated taboo. So there, I feel that we can educate the society as a whole. The initiative needs to be taken by us. We have to tell that this is just another disorder, and if we take care of it properly, the average lifestyle would be very nice. Recently, as I was mentioning during my talk, I have a girl. She is a dental student, and she was in her hostel, and she was picked up about 20 hours into hypoglycemia, and she is almost brain dead now, sir. So these are very unfortunate things, but I wish we had more time and we could look into these things, the psychological factors, what has preempted, and whether she has taken the extra dose of insulin because of prevailing depression, etc. We won't know at this stage now. So these are the things, the unfortunate things that happen. But if we are aware, firstly as a physicians, then we can make the family and the society aware. I think it would be a great boon, sir.
So there is a question for Dr. Jayaprakash, Dr. Vanjanathan. How can we manage hyperglycemia, fasting blood glucose 250 milligram, postprandial 360 milligrams, in young overweight male of 42 years, already on and not controlled with metformin, pioglitazone with mild transaminase, ultrasound showed fatty liver? Can we add SGLT2 inhibitors or insulin in that situation?
I think the question is to manage hyperglycemia. Managing hyperglycemia in that case with both fasting and postprandial this high, the best option would be to add a basal insulin. Addition of an SGLT2 inhibitor would also help in this case, both because he is overweight young individual. First, I would actually start with basal insulin, take control of his hyperglycemia, because uncontrolled hyperglycemia is also one of the factors which lead to kind of transaminitis and its evolution into steatohepatitis. So control his hyperglycemia, add a basal insulin. Yes, SGLT2 inhibitors can also be added. And once this improves, one is able to lose weight properly, we can take off the insulin if things are going on well and continue his SGLT2 inhibitor. Addition of a GLP-1 receptor agonist also would be an option for him.
Yes, sir. Next is, we have patients with diabetes developing non-alcoholic fatty liver disease and subsequent progression to NASH and cirrhosis. And we have patients presenting with the cirrhosis and hyperglycemia, what we call it hepatogenous diabetes. So to differentiate type 2 diabetes progressing onto liver disorder and liver disorder producing hyperglycemia with reference to complications. Yes, your comments, Dr. Jayaprakash.
I think the evolution of the disease would give a clue. An overweight, obese individual with a family history of diabetes, developing diabetes, pre-diabetes, along with that fatty liver, and then diabetes. So that is the common diabetes kind of coexisting with fatty liver disease and evolution to cirrhosis with a possible contribution of alcohol to that. That's what is a common scenario. But as you said, there are a certain subset of patients who have liver disease primarily, liver being a site for insulin resistance and of driving this steatohepatitis insulin resistance, proving it to produce hyperglycemia and diabetes. Actually, those are the second type of patients who are actually, we find it more difficult to manage because we are at a loss with drugs like, say, metformin is not very useful in these kind of patients. Early on in the course of disease, if you're identifying these patients and adding pioglitazone in them, and probably with the emerging evidence with SGLT2 inhibitors and GLP-1 receptor agonists helping these patients, probably it would be helpful to find these type of patient subset.
I have a question to the entire panel. How has the COVID lockdown affected the psychosocial aspects in our diabetes management? And everybody's experience a little bit, I would like to hear the lockdown and the COVID illness per se.
Yes, sir. So first of all, patients with normal glucose tolerance prior to COVID and now land up with hyperglycemia because of the COVID infection, as well as the drugs what the patients were given for the management of COVID. And patients present with a very high plasma glucose level, very high plasma ketone level. Some of the patients we admitted in a hospital and we give intravenous insulin along with the supportive measures. And we, at the time of discharge, we put the patient on basal bolus therapy. Patients already on treatment for diabetes after COVID, that is after SARS-CoV-2 infections, psychologically depressed and psychologically anxious. So that status with reference to glycemic control is very, very poor. And we need to counsel them. We need to put the patient on low dose antidepressant with anxiolytics, along with motivational therapy, proper education, as well as we manage the patient, foster the patients with a combination of oral antidiabetic drugs on the top of with insulin.
Dr. Shastri?
In my experience, like in the initial first lockdown time, majority of the people started getting better HbA1c once they started reporting. So it's a little, because they're not able to access the doctor, and they started disciplining themselves and eating home food and not going out, and those things might have contributed to better HbA1c. I'm talking about those people during the COVID times, not affected by COVID. And those affected by COVID, sugars went every, and because of the treatment and other things, steroids, pulse therapy, which people are giving, and sugars going up to 400s, 500s, and we had to give extra care to them. So both impact is there.
I also totally agree with you, sir. In fact, many patients also started skipping their doses. Because the drugs were not available, the pharmacies, etc., were closed, and they were not properly stocked for these medications. Even then, few of them, they did not have any major differences in their glycemic control. On the other hand, some people had very bad control. They came with 400, 500, and so on. And since during COVID time, now I'm in Delhi, I was posted in Guwahati, and I was doing the duties of HOD medicine also there. So we used to be getting acute MIs and strokes, etc. Also, I found that those also reduced. So maybe the stress level also came down because of the frequent traveling and all those things. Though my population was only the services people and their families, so they're slightly more restricted, slightly more in the cantonment environment. They are more protected that way. So the number of thrombolysis that our physicians were doing per se, that reduced drastically. It came down to about 1/3. Similarly for acute strokes, etc. Also, so maybe the stress levels have also gone down as during the period of initial lockdowns. But once these things started opening up again, things have gone back to the normal. I mean, the pre-COVID levels.
With all these things, and the home cooked food, once that initial part is over, actually the control worsening in most of the patients. And the fear of COVID, the fact that diabetes aggravates and makes the more predisposed, made many patients to start controlling the disease. That's what I found out here. Many people who were on alternative medicines, the homeo and other things, the A1C of 9, 10 and all, they started coming to us wanting to control diabetes for the first time. So that was one of the things which I think was probably of advantage to us. Now that fear of COVID has somehow gone, COVID is still with us, people have started going back to their old ways slowly. So I think it's a matter of time only before things go back to the original way.
As personally, as me, as a doctor, I realized that coming home at 6 o'clock is equal to coming home at 8 o'clock. I used to come home at 8 o'clock before COVID. A little bit of work-life balance has improved for doctors as well, a little bit.
Yeah.
Because of COVID. So socially, it's affecting us also a little bit. So,
I hope that we carry it forward. Don't take care of our own health also.
so shall we call it a close, Dr. Hari?
Yes, sir.
Yeah.
Thank you so much for the wonderful opportunity given to chair this session. And we learned many things from Dr. Jayaprakash's lecture as well as Dr. Vimal, his talk on depression, anxiety, general panic disorders, generalized anxiety disorders and panic disorders. Really excellent, sir. Really excellent.
Thank you so much.
Our
Thank you, Dr. Hari Kumar and Dr. Santosh. Thank you very much.
Just to give you statistics, our talk was heard by 230 people right now.
Oh, nice.
We are 5 people on the screen, but 230 people have heard us. So I would obviously take the opportunity to thank the delegates first, because delegates, if the delegates are not there, the conference is not there. And of course, there is an immense effort from the speakers to prepare so many slides, chairpersons to take out their valuable time and give their valuable comments. And also the backup IT team was very strong today. No glitches have occurred. So thanks to them. And obviously thanks to all the sponsors as well. So all of you who are attending here, either in the faculty Zoom or are listening as delegates, we invite you to even attend our meeting next week. Next week also we have the meeting around the same time only. We start at 9:30 and wrap up before lunch so that you can spend time with your spouses after that, or sleep or do something on a Sunday. So with that, I think we should close this hall, and the delegates who are listening can shift to the other hall. An interesting debate is going on now. It will end at around 2:15, and then the entire program will be shut for the day. Thank you.
Thank you.
Thank you. Thank you.